meeting Flint Director Barnsley and Gareth Barnsley. Lovely to see you. Great to see you. And Greg Fell, who many of you know, who's now our Director of Public Health. I was going to say he promised to behave, but you didn't, did you? No. I had a pre-joining conversation with him. Yeah. I've been warned. You've been warned. But I'm not sure it'll affect your behaviour. Anyway, welcome. Good to see both of you. Okay, I've got no apologies received. Is that still the case? Some people are joining online, I think. So, okay. Declarations of interest today, okay, nothing to change. Minutes of the last meeting, are they all right? Richard, you wanted to look at the wording or something, is that right?
Yeah, so just on page 18 and 19 here, so it basically just needs an extra word. So on the,
could you speak up slightly? I'm slightly struggling to hear you.
So on page 18,
thank you.
Towards the bottom, third paragraph on the bottom, it's talking about paediatric audiology services.
Yes.
And the sentence says there is current review of children's services. And actually the review is of children's audiology services. And so it's just for a point of clarification.
It's more accurate, that's right. And that was what was said.
There's another question or point really under 19. And I'm Chief Executive of Doncaster Ambassador Teaching Hospital, so I do have a conflict of interest in terms of getting it right. Under the section where it talks about the visits to A&E, it says that due to the challenges within Doncaster Hospital, I actually was of the understanding that those visits were undertaken in all hospitals across Doncaster and Bassetlaw, Rotherham, Barnsley and Sheffield. Nobody mentioned it was specifically Doncaster only.
It was Doncaster and Sheffield teaching were the ones that were included specifically.
My understanding of two laboratories.
So if the minutes could be amended to say that then, so it says at the minute due to challenges in Doncaster, actually Doncaster, Sheffield.
That's fair.
Yeah.
Thanks. Thank you for that. I assume the minutes other than that okay. Breathe, thank you. Anything on the action log I need to be.
No, which is the matter arising because there's an outstanding action with regards to virtual ward economic evaluation.
Yes.
The full evaluation wasn't expected till the beginning of 25-26, but we are getting some early interim information from there. That's attracted some national attention of that. I think Greg, you emailed me this morning to sort of say, you know, this hasn't been done and you know, kind of it's difficult. So the headline findings are we have had the increased utilisation in the winter. We've also had a number of beds that have increased, and you know there are impacts of that, significant reductions of admissions and bed days. The full evaluation needs to be worked through. David Lawton has offered to come back to one of the development sessions if we want to take him up on that, just to give a bit of more detail on that. But for today, that work is ongoing, so we leave the action open, but it is progressing, and I think it's a longer piece of work.
That's fine. A couple of things. One is I think it'd be helpful at some point, but actually I think the place committee need briefing as well, because there might be nuances in each place that are slightly different. So I don't think the board great to come to the board, but it's more than that. Okay. Thank you. Thank you. Anything else? Okay, we now move on to storytelling. Katie, you can do the introduction.
Hello. Right. So as you know, this is my third storytelling that I can do for the board. So the first one we managed to get the members of the community along. The second one we had Izzy on the screen. Today we have a video. We worked with the advice of Doncaster and Kate and Emma before we watched the video as well. So we've let them film the video because I wanted it to be in, the gentleman is called Neville, so I wanted it to be Neville's words and I wanted it to be comfortable. And they picked me up on it not being very split. It's because it is about Neville, not about the conference. So Anthony got in contact with me and he said, we've got primary care papers on the board, it would be really good to do a storytelling that tied in with that. So we've done that. I spoke to Katie who immediately said, this is really good, and they immediately thought of Neville. It's a really good example because it talks very much about the partnership work that's happening around primary care and really ties into the sort of the left-shaped neighbourhood working working with the voluntary sector stuff that we're looking at the moment. So Neville will explain why that's really good for him. And obviously from a citizen involvement point of view, I think Neville's a really good example of why we do need to listen to people when we're planning some of this stuff, because Neville's experiences are that he comes into contact with citizens because they are positioned in the GP practice. And I think it would be easy for us to think, well, Neville had a advice office down the road, why didn't he just go there? And I think he really articulates why sometimes it's about bringing the help to people. He's a really proud South Yorkshire man who's never had to ask for help, so he doesn't want to ask for help. And it's the fact that the help is available where he needs it is really important. I think the other thing, just to say quickly as well, is you'll notice that some of Neville's challenges are around the fact that he's on an NHS waiting list. And for me, this is a really strong articulation of the people behind the numbers. So, so I'm going to let Katie from ICB and Henna from Citizens Advice. I'm going to have to tell you a bit about the project, and then we'll hear from Neville.
Thanks, Katie. Hiya.
Hello, good morning. Thank you. Hi everyone. So I'm just going to do another quick intro into why we established this service, and then I will tell you a bit more about it. So fresh out of the pandemic in 2023, we saw an increase in demand on primary care services, heightened by the pandemic and also the cost of taking its toll on people's everyday health and well-being. And as Katie just said, with individuals often not knowing where to go for support and ending up in front of a trusted GP in a safe place. During the pandemic, we've seen the value of working with voluntary community organisations in helping to get people the all-important vaccination. And so we've seen that working really well, and wondered if there was a way that we could work more closely with people, making them more visible in primary care settings. During the pandemic, I was in the room when the Director of Public Health in Doncaster referred to Citizens Advice as the fourth emergency responder. And we saw such a significant rise in cases as part of the pandemic. And so, as part of a team in Doncaster, where we recognised that increase in demand, we wanted to try and help relieve the pressure on primary care services and provide more support to people in Doncaster. So at first we commissioned a advice on prescription pilot working with one primary care network in Doncaster. The power of Neville's story, as Katie said, is the impact it has on him. And something that, had he not seen the visibility of Citizens Advice, he might not. The other thing I just want to stress before I hand over to Emma is that we're also making Citizens Advice service visible to our health and care professionals, because they're not always confident in referring on to others. And what we see in the video here is that the care coordinator was confident enough to send Neville over to Citizens Advice. And I'll hand it over to you. Yeah, thank you. So I've been really lucky to be involved in this work, the pilot that we have in that one centre in Acton. It was really a learning curve for us, which allowed us then to sort of move into the 8 practices that we're in now. So we really integrated ourselves as part of the team, the reception staff, and so they could understand what Citizens Advice actually do. Gone are the days where you'll go take a ticket and sit and wait. There's so much more to what we need. And most people that come to us now will come with what they identify as maybe one problem and leave with actually 5. So everybody's living more complex lives. The work that we do in a more complex. We've got specialist teams that now, patients and even staff members. We've had staff members across the practice. So being involved in that pilot and then seeing it now at the end of year 1 across the 8 practices that we've been, and the impact not only on the people, but like I say, the practices and the staff there. And then looking at things such as you'll see in the paper, the income gain in 1 year. Across 8 practices, 1.3 million in unclaimed benefit is what our 2 staff members have managed to support with. That's 578 people that have received an increase in their income, which will then hopefully impact on their physical and mental well-being. Looking at things, we use the word measuring tool, not just looking at the numbers. It's not about how many numbers of people we've seen or how much money it's worth. The impact on the people that we're supporting. The evidence from the Web survey is showing such a massive impact. So 79% of people say that they can better manage their own problems. It's improving their lives. 66% of the people that we've seen are saying that they've reported long-term health problems, and you'll see from Neville's story. The support that then it offers you, your practices, is that they're not turning up to GP practice non-medical issues. It helps them sort of manage, and our biggest tool is to empower people, eradicates that dependency on other services. So the monetary side of it, but then the impact on the patients themselves. For me, that's my private part of being, involved in this project. Seeing it go from 1 across to 8, and hopefully it'll be it's just fantastic. And also, I was just saying, from a staff point of view, working on a project like this gives such immense job satisfaction because you really are helping people. It's not, it's not about the data, it's about supporting people like me.
Brilliant, thank you.
Hello, my name's Megan. I work for Citizens Advice Doncaster. I'm based on the AOP project and I'm a general advisor.
Hi, I'm Neville Walton, and at the moment I'm a client of Megan's.
That's the one. So from the start of your journey, can you tell us a bit about your life before you got help from CAB?
Well, I split up with my ex and I got made redundant, which was a very nasty boss because he always threatened me with it, which used to depress me, which drove me to alcohol, even in the workplace. And I ran a bit bad way, but then I ended up living in my house on my own, with no job or anything, and I was really struggling for money, which depressed me even more. And all I did really was borrow money and drink, and didn't eat very good.
No. You mentioned as well before, Neville, with your upcoming the operations. I know you're still yet to get a date. I hope you don't mind me saying you.
Pre-op this Monday coming.
Oh, brilliant! Lovely.
That's good.
Lovely. That's good news then. But you mentioned before that you used alcohol as some sort
Yeah,
of
pain relief. Yeah,
pain
yeah,
relief
that
as
as well, but kind of mixed in with work as well.
Yeah. In terms of sort of drinking alcohol and things now, I know you mentioned before that you'd reduced it.
I've known Foster for 5 days.
Oh, that's brilliant. Really good news. So one day you was at your GP practice. What made you decide to come in and speak?
I came to him because I was worried because of depression. I'm pain in my knees, and because of the depression, he put me on somebody called Jane.
Jane, yes.
Jane, who works in the back behind the scenes at run to practice.
Yeah.
And I had a few conversations with her, and then she put me forward to Megan. I can't remember if I was Megan or Megan will be off. She made the appointment. I can't remember that.
She made a referral through our health referral sheet. So Jane is the care coordinator for South Primary Care Network, and she put the referral through to myself through the health referral sheet, and then I got in contact with Neville.
Maybe I was thinking, because at the beginning I think I was on something like £87 something a week, and since because of the financial side, but once some more money coming through, your name's going out of my head, Megan, I'm eating healthier, I feel more confident in myself, I'm feeling really good at the minute, but I'm on a bit of problem with my daughter at the minute. But I'm just hoping this Monday goes really well. I'm just so grateful. You say, well, tell me I'm a success story, but I think it's everybody. Everybody who's been involved.
Oh, brilliant. You are though, you know, we've given certain tools for you to be able to make positive changes and things, but the real change is the change you've made yourself. You know, you've cut down on drinking, you've started exercising, you've used support groups.
Yeah, I'm doing swimming now.
Yeah.
So that gets me up and out.
Exactly.
Getting out a bit more now. Not out drinking or anything, but sometimes I go to my brother's in the morning to the office or in the evening. Gets me out. I'm thinking about starting fishing. I can't walk very far at the minute, but these days you can park next to the fishing boat.
Oh, good.
So I've been looking on eBay for a bit of fishing just to get a bit of fresh air or
why not?
just get out.
Just on the back of what you said there as well, we applied for the blue badge for yourself as well.
Yes,
didn't we?
I've received it, I've used it straight away the first day.
Brilliant.
I went to Big Asda, I didn't do the walking, my ex went and did the stuff with me. But we sure parked to the nearest cat parking bay to the door and it were right.
Which that in itself.
And I'm actually parked now in the disabled bay here.
There you go. So it's cutting down on putting that pressure on your needs as well,
Yeah,
isn't
that's
it?
right, yeah. A lot of things I struggle with because I'm a bit deliberate and it's hard out. Sometimes I read things, like obviously I can't read some words, so I have to try and guess or what some things. Read the same sentence about 5 times.
Yeah.
And then it's like normally comes to me, but sometimes. But no, I wouldn't be able to fill the phones with me out again. It'd been like one word answers and I wouldn't have got anywhere.
That's what we're here for.
More friendly atmosphere. Don't get me wrong, Megan makes you feel so comfortable. So that was fantastic, like, because I do get a bit upset and I've got quite a nice speech, especially when I'm talking about my problems. Because I've worked all my life, I've had my own business, been successful, and now it's like the other side, and I felt worthless, to be honest. So, I think that's it.
Good. So being in a trusted place, such as you do,
Yeah,
certainly helps.
Yeah, but it's easy to get to as well. I mean,
Yeah.
don't get me wrong now, I've got the parking badge like I'm somewhere else. But it's familiar. If I had to go somewhere else I didn't know about,
Yeah.
it gives me a bit of anxiety. I don't know where parking is or anything like that.
Yeah,
But
understandable.
it's nice to be like your local ground, you know what I mean?
Yeah.
Yeah.
Yeah, it's in your community, isn't it?
Mm-hmm.
So on our first meeting, Neville, we discussed council tax reduction.
I didn't know how we entitled to that.
No, we didn't, did you? We did the benefit check, and that was one of the first
Yeah.
things that had obviously come up. So that council tax reduction has obviously saved you £1,508.52.
Brilliant.
I mean, it's a big amount, isn't it? That
It is,
you know you're able to claim. So that obviously helped to relieve the financial load. Upon doing the benefit check, we obviously found out that he was awaiting a knee operation. That you'd got obviously anxiety, you've not been in the best sort of health-wise. I know you've obviously got other health conditions, diabetes, blood pressure and things. We then started discussing PIP. We put in the application, we called the PIP line, we secured obviously a nice back pay for yourself, which again, that's a financial lump
Brilliant.
sum up
Thank you,
front. So PIP is obviously a disability benefit from pension age, personal independent payment. So we applied for that. We was able to get the standard rate for daily living. So that's all things in aspect of sort of preparing food, toileting, washing, bathing, a variety of things that affect you obviously in your daily life. So we got the standard rate for that, which was £108.55 a week. That was obviously a big step. We also then applied for the second half of PIP, which is the mobility side. We got the standard rate for that, which is £28.70. Overall, your weekly and your monthly income is
You've got your York garble.
£7,137 a year. You've gone from obviously working, being made redundant and missing a big chunk of money. How's having that money put you back on financial ground?
It's nice. It's nice. Before I came here, I've just had a banana. I never had bananas before. Well,
Yeah.
because of the drink and the cigarette, well, I smoke as well.
Yeah, so it's
They are
helped
asking people.
with travel, it's helped with food costs.
Yeah, food, I mean, a lot better. I'm losing weight.
Brilliant.
So, I don't think that's also in my life, but I'm not drinking as much anyway.
Yeah.
Not smoking as much.
Yeah. Positive life change though, isn't it? It's, I think, given the tools to do
Well,
what we've
I'm not
done.
depressed.
Yeah, because you're not worrying.
Before I would talk to myself and everything, but don't get me wrong, all the time I like hearing myself talk to myself, but not like a lot.
Yeah. We also did the ESA employment support allowance. We did the rate change for that, so you've gone from the working rate component to the support component. So that's obviously you've got the health conditions which we discussed, you've got the disability benefits, so it had a sort of passported benefit onto the employment support allowance to be able to give you that extra income with you not being able to get up and go to work, awaiting your knee operation, your health conditions. So that's improved your financial income to about £480 a year.
Yeah, I mean, I am hoping to go back to work.
Yeah.
I mean, I've never ever asked for anything, but I've met you.
Exactly. If you're entitled to it, Neville, you're entitled to it. They wouldn't give you money that you're not entitled to.
No, I'm just so happy at the minute. A lot better place in my head and everything.
Brilliant.
Well, I'm very, very grateful, like, but I never really knew about citizen advice, about what you could do for me without Jill, Jane.
Yeah.
But since I met you, it's like, well, my ex-husband, I'll get them put after shaving for Megan. Because it's like, it's nice to come. I'm not scared to come.
Yeah.
Like, it's so place. It's like I've known you for years.
Yeah.
It is. You do make it so comfortable,
Oh, God.
but thank God that you got some good staff.
Yeah.
That's it. I mean, I don't know what I can say apart from how grateful I am.
Oh, brilliant.
Totally different place.
Good. Glad to hear.
Yeah. But no, a lot better. A lot better.
Good. You know, I know you're saying thank you to us, the citizens' advice, but we've given you tools as well, you know. To make them changes yourself. It's, you know, as much as we can help, you've really helped yourself as well.
Yeah, no, I appreciate that, but like you said before, like with extra income and everything, I might not have changed.
Yeah.
Might have been worse.
Yeah. So. Good. It's a journey from start to finish. I think this has been sort of 5 months worth of help from sort of start to finish, but it's been a different agenda sort of each time. But coming back to myself in the GP surgeries in a trusted place, and knowing that you've got trust in me to help you, that means a lot as well. Because
I ain't been embarrassed telling you about me reading, my writing. I just felt so comfortable.
Good. Lovely.
I won't put anybody else on to you, to be honest. I mean, I wouldn't put anybody on apart from for you.
Yeah.
That's what I meant to say.
Thank you. That was brilliant. No, we had difficulty. Would it be helpful if we could circulate that to the board later, just so because we missed some new ones in the middle of that.
Yeah.
That was great. But, Katie, thank you. Anything you want to add?
I think one thing I just wanted to say is that there are some variations in the other 3 places. And what we're looking to try and do, and certainly at the moment, can we have some sort of standardised offering across South Yorkshire? It might be a hybrid, and Rotherham are about to pilot having some kiosks in primary care settings. I think we can use kiosks to get some. It'd be nice to have complementary services. But you can see there from Neville, there were multiple things that in some cases might seem really small things, but the blue badge, the fact that you can have that blue badge and that you can live a more independent, and you know, it actually starts to see a change in him, and that you say he wants to go back to work, he wants to do things to keep well and independent. It's just a wonderful, wonderful service that we're really proud of, but just to emphasise that visibility in primary care.
Go ahead.
Just to show them, the thing that point out to me was the banana, like, not it's amazing. But then the keeping 5 months worth of work, it's not just a one-off appointment, it's case work. We really try to support end-to-end with that, and that means that they are advisors, you know, the more advice we have about anything, the more.
Got Greg and then got Anthony. Greg.
Katie, happily held strong believer in this. That's all the main funder of Sheffield CAB. I think worth the benefit, which is interesting. But happy to help on that one. I'm a strong believer. There's a conversation about on NHS premises versus not on NHS premises. Yeah, there's a conversation to have versus online, everyone on CAB. Their demand has gone up like that, their funding is like that, and there's a really everyone councillors talking about that all the time. It needs some careful handling. And the last quick thought David may have used on this from John's perspective, how does this fit with a whole bunch of other stuff on income maximisation, which are kind of local authority and etc. That needs a bit of management together. But I'm strong.
Got Anthony, I've got Lisa. Anthony.
Thanks, Greg. I'm surprised that I'm a strong supporter of this as well. I think Neville speaks for himself, doesn't he? I think the learning from me is Neville did this by going through a GP appointment, and that's how we got in touch with the advice. What we increasingly find is that over 90% of the diabetic patients are in primary care. That's obviously given the football this sort of in, but actually, what we're finding is that Neville, perhaps there's issues when we talk about demand in primary care and the ability for GPs to give that kind of advice in 10-minute appointments. It's not there. Actually, Neville, the vast amount of these issues were not about the medical contact, and that's really given him the in there. The other thing I wanted to make, and I'm conscious where I'm sitting today, and the primary care paper will later on in the agenda will highlight some of the risks we have with some of this transformation. It's funded on non-recurrent money year after year, and how we're really committed to this as a board and as a system. How do we make this mainstream? And this is just one example of some brilliant work that's funded in that.
Got Lisa, then I've got Lucy. Lisa.
Okay, so thank you for presenting this. It's been really useful. I think it just shows a typical patient who's a man. It takes a lot for them to get to see their trusted GP. It's taken a lot to get them there. So to then send them somewhere else is really difficult. So we need to have those services and be able to signpost to them straight away. I know we have social prescribing, who do more or less the same thing. It's amazing how many people you meet that are not on benefits, they're not getting any money, they have no heating, no water, and they're just surviving because they're strong and they're Yorkshire people made of sterner stuff, and they're proud. And sometimes it's their literacy that they're embarrassed about, so they don't ask for help. So it's so important that we go out and we opportunistically give these people help. Sorry, I work for SACMA, which is Sheffield African Caribbean Mental Health Association. And we've now employed an advocate from the Citizens Advice Bureau on site. And that has made a huge difference, because when they're coming for help for one thing, they get help with other things. And like Anthony said, most people's problems stem from non-medical issues. So it's more important than medical stuff sometimes. So we really do have to prioritise this.
Lucy, and then David. Lucy.
Okay. This is a really brilliant opening to our conversations about primary care, because I think we've reflected before that the data that we often look at really isn't sort of getting under the skin of what day-to-day life in primary care is like. And we've been hearing a lot recently from both the public and staff in primary care about how, as Lisa describes, a lot of the day-to-day pressures stem not from clinical need, but from these kinds of circumstances. And the pressures are huge, and we hear from patients how deeply frustrated they are not being able to get the care that they need. And the other side of the story is that staff are under enormous pressure. So I think probably none of us are surprised that this works. I think we probably would have all have hazarded a guess that an intervention like this would be successful. But it's brilliant to see the evidence and to hear the stories. And we know that similarly, there is evidence and evaluation to show that it's worked in Sheffield. So I just echo everybody's challenge really about how do we move that on to a decision about, we know this works, so what do we need to do to sustain it? Thank you.
Thanks. I've got David and Leslie. David.
It's a bit of a broader point of clearly the benefits are highlighted in this, but anybody who's listened to the radio on the way in knows that the strength statement due on the 26th of welfare highlighted as an area that will get a focus. It kind of goes against everything we've mentioned here, because will that offer still be there for people? So I guess it's just us be mindful of, we'll help these people, but the rules might change, so it's going to be difficult.
Leslie.
Thank you for the story. To me, it's not a surprise. I spent 30 years working in voluntary sector, worked in organisations that provided I think from working in Rotherham, certainly one of the key components that I always saw around social prescribing was that advice component within that, and that's been strongly funded. And Shafiq and me all the way through, and I think that is so important in terms of those wider determinants we keep talking about, but also the health inequalities. And I accept what David's saying. I think there may be even more pressure on people's side coming, but also we know that it does help people to stay away from the NHS. So it is improving people's health in a way that is different. And I think that's really important. I just want to flag up that there are a number of organisations across South Yorkshire, sorry CAB, but not just the AB, and we shouldn't get caught up with that. Age UK is doing that stuff. There's a number of disability organisations, Style, Active Independence in Doncaster and Rotherham. So we need to understand that marketplace, that what's going on out there, and there is a massive amount of work already happening, and actually we need to add to that as well. So understanding what's on the ground is going to be really important for us. I'm not sure we do. I remember 10 years ago, probably, having a conversation, maybe a little bit more than that, having a conversation with Chris about the fact that at that point, the NHS never really engaged in conversations about funding our bands. And it was usually local authorities that funded our bands. That's really changing, and I'm pleased to see it changing, because I think it's bang right for what we're trying to achieve as an ICB.
Lee and then Christine Lee.
I am hugely supportive, but for me, it just amplifies this when we get into some sort of total place conversation about how we start to dial together a very fragmented state of it. So I'm aware of a practice in Doncaster that's got DPP working straight into it, one day a week to try and directly provide that benefit to us. So the benefit system feels like something that's accessible. The candidate is kind of that day that you so often navigate, you don't get what did you. So what I'm really interested in is the cause of it. As a board, we accepting of the state offer is so fragmented, we need the third sector to join it all together. Or is there something we need to be saying about reinvigorating that whole notion of place pilot, dealing something like that in a holistic way? And do we just need to accept that we've got so locked into different silos of the state delivering different things that the sector is just going to compensate for that? So I'm not saying CAD doing anything wrong, but what they can do, then of course, cause them is compensating for a really fragmented offer. And the consequence of that for a medical offer is obviously more interactions with general practice level than you otherwise have. You can get a more sense of place, sense of things. So I don't think we're doing anything wrong. But what I'm just interested in is no wash with money. Talk about it later somewhere. So is it the NHS's role that happens to
A couple of us, and then I'll ask you to come in the end, Kate. All right, so we've got Christine, Jahida, Greg, and then I'll ask Kate. Okay, Christine.
Thanks, Piers. I just wanted to connect this word to the word of the economic connectivity work that's happening across South Yorkshire in terms of the economic connectivity trailblazer in the health and very much sector. There's a lot of mapping that Leslie just talked about the different services that are available in different places. And I think that it is incumbent on us as commissioners to try and stitch that together across local authority, across all DWP, across health. And so I just want to make that connection, and I'll connect in with yourselves outside of this meeting just to make sure that we're learning. Because the other thing is about learning from what we've got, can we scale? If we've got a proof of concept as commissioners, are we going to scale that then or not? Do you know what I mean? But we need to understand the impact.
So Shahida, then Greg, and then Kate.
Yes, I'm just going to pick up on that point that Leslie made and then the point that we made, and that is around the third sector. Quite often, traditionally, we view the third sector as our fourth, third cousin until there's a crisis, and then we're all reliant on them to keep the connectivity. I think there is something to be said over the last 15 years, year on year, we've lost 30% of the VCSE sector in South Yorkshire. So we have to make a decision about, one, understanding who's on the ground, because there's organisations that get left. The reason why, as Greg pointed out, CAB demand's gone up here and funding's down there is because the supply chain for the VCSE sector, more and more organisations are getting squished in the middle, or either facing closure, and so the ones that are left behind are having to pick up the people that would have been supported much wider. So I think there is something to be said about Christine's point. If we're going to scale it up, are we invested in that infrastructure in an appropriate way? And secondly, just also say, and I take some responsibility for us as third sector as well. We have conceded the ground. Too often we've conceded the ground. We've kind of had to plug the gap, as Lee said, when that offer of, the public sector, the health and all the rest of it, we picked up the pieces.
where I think unfortunately you're going to find in the next, certainly this year and over the next few years, the third sector will significantly push back. It has to, it can't afford not to. So I think there is a question about how do we see it all together? How do we get a holistic approach? Because as Lisa said, 9% of the time when people walk through the door, it's not help.
Greg.
Quickly build on these points on sort of place briefly. What geography? I've recently published my annual DPA report on poverty, covered all of this in very great detail. I'm happy to be the stitcher for the level of Sheffield. I can't do it South Yorkshire, 2 minutes, 9,000 a day. There is a resourcing basic service delivery, CAB and other providers in the mix there, and the properly resourcing the infrastructure to do which none of which the DWP needs to be in the room. And I think one day this point, I'm deeply worried as to what may or may not pass with I think that the pitch is being rolled out.
Katie,
thank you. Yeah, I wanted to respond to Glenn's point. Part of us considering what the future looks like for this particular part. I wanted to just do the digital inclusion point of view and how it's absolutely underpinned by social infrastructure. It's using all of our wonderful community assets, voluntary organisations, but what we need is coordination. So what I found when I first established the digital inclusion programme in Doncaster was there was already things happening, but in very siloed ways, and just by starting to coordinate and come together, we were going further faster and making more of an impact, and that's something that we've widened across Yorkshire. So what I want to look to do is do some sort of combination of that, and it's proven to be really successful. What we're asking is for organisations, statutory and non-statutory, to be advocates of each other's amazing work, and like I say, have a common goal in place. And the reason why systems advice has been crucial to both pieces of work is the addressing poverty. So we're addressing poverty in its fullest sense, from the financial and the digital point of view. And I think some of the points that come out today is that people have got issues but wouldn't necessarily go, I've got a digital issue. They don't know that, but what they've got an issue with is accessing information and accessing the services they need. And so I would say we do have a role. I'm really passionate about the fact that I think we've got a role, but it's in that coordination and that bringing together.
It's a really good way to finish. Can I thank you? Katie, nice to see you again. Nice to meet you. Please, really thank Neville as well. Megan, that'd be great. If you could circulate the presentation, that would be really helpful. Is that okay?
Yeah.
Thanks very much. Brilliant. Thank you very much. Nice to see you. Okay, I think that was a really good way to start the board. Thank you for that. I haven't got much on shares matters. Two things just to note, and there's been significant changes in shares at the national level. And he'd actually appointed to NHS chair 2 weeks ago, picks up a role on the 1st of April. I know Penny well, this will not be business as usual. I think that's fair to say, and I suspect she was chosen by Secretary of State for that distinct reason. And I think there's a lot going to change around the accountability of ICBs, accountability of trust. It's a discussion we will return to April, May is my guess, but I think that'll be a big change. Also, a significant change at CQC where Mike Richards has been appointed Chief Inspector. That follows the appointment of the new Chief Executive in Julian Harvey. I think most people would say they would welcome change in the way CQC inspects, and I think that is coming. And that's a good thing, and that follows the book that Penny actually wrote before Christmas. Big changes, I think they will impact upon us. They will impact upon our providers significantly. Because I think the whole inspection regime reflects significantly on our group. That's all I've got at the moment. Gavin, can I hand over to you?
Thanks, Chair. So I agree. I think Neville's story was a terrific place to start the board. I think it does touch on quite a lot of the things that we'll talk about today, particularly that sense of, I guess, what we often call the wider determinants of health, the fact that there's a lot more to encouraging people or supporting people to be to remain healthy and supporting their well-being than simply NHS services. It really is about how do you integrate across what is a fragmented landscape. I mean, there is a lot going on nationally, so just to draw out a couple of things, we're in the midst of the national consultation Change NHS. which is one of the contributors to the development of the 10-year health plan, which we're expecting within the next 2 or 3 months. I am, despite the name of the consultation being Change NHS, I am hopeful that this will be a 10-year health plan and face into some of those issues about how do we work in a more joined up way across the, particularly the public sector, to respond in a more kind of integrated and coherent way in terms of population, the needs of people who rely on our services. I think what else has been clear is the government's I think restatement of their sense of direction for the NHS over 3 shifts. We hear a lot about, so that's the move towards prevention, that's the move away from over-reliance on secondary care, which was highlighted in the Darcy report. A movement towards care closer to where people live, and also the application of digital rather than sort of analog technology. So we're seeing a kind of a clear focus. I think the other message which is coming out really clearly, I think, is this idea that the NHS must live within its means. So David's already mentioned about the upcoming kind of spring statement, but I think that's it's really clear. And I was reflecting on this last week. Really, when you hear the government say that there is no more money, believe them, and you only have to look at, for example, the move last week to bolster defence spending for reasons we understand, but at the expense of the international aid budget. That's a signal that the government has very little room to manoeuvre. So I think we need to heed that message. So when Lee is describing not only the current financial position, but also the planning process that we're facing into, we really need to understand that context. And of course, we want to see a shift of resources out of secondary care and into primary and community services, and that sort of integrated neighbourhood model. But to do that, we need a plan that enables that shift, because I think relying on additional funding to come centrally, I think is we might find that we wait a long time. So that's the sort of headlines. I guess the operationalisation of all of that is within the NHS planning guidance that were published in January. And we've got on the agenda a focus on our approach to planning, which is really our response to those national planning guidance, which really sets the short-term direction for the NHS over the next 12 months. We'll come back to that later in the plan, how we're developing, later on the agenda, how we're developing our plan. But I guess just to pick up a couple of themes. The first thing that I would say is that there are fewer high-level national targets within the planning guidance, and there's also less ring-fenced funding. And I think what I read into that is what the government are trying to do is to give the NHS, freedom to manoeuvre, given the constraints that exist. I think they're trying to give us some latitude in terms of how we operate and the choices that we make locally. So I think that's a good thing. I think we welcome that. But as I've said, the financial challenge, I think, is considerable. So I guess the headline numbers are, although it's true that the governments have put in additional resource into the NHS, much of that has gone on pay awards, on some of the settlements that have been reached with different professional groups, and also things like the increase in national insurance contributions by employers. So I think the reality, although additional funding has gone in, is that frontline expenditure will feel like a reduction, and in the planning guidance it talks about a 1% reduction in frontline expenditure. It also talks about a requirement for a 4% increase in productivity across the NHS. I think last year the NHS did pretty well and delivered a 2% improvement in productivity. 4% has not been achieved before. So to say that that's a significant ambition, a significant stretch, is probably an understatement. So we've got a lot to do in order to deliver a plan which meets those requirements, both to improve access to services, but also to live within our means. So we'll come back to that as the agenda goes on. I think the headline for the system is that we do need to accelerate our approach to transformation. So that's looking at how can we work together differently in a way that actually improves services, but also eliminates waste and takes out some of the duplication that we see within the NHS in order to sort of square the financial challenge as well. So in terms of the headlines for that plan, we've already submitted the draft, position statement at the end of February, and we're working over the next few weeks with system partners, particularly in terms of a final submission, which we'll post at the end of March. So we'll hear more about the detail of that work, but absolutely critical. Probably just to take a slightly different tack, we had our Integrated Care Partnership meeting in January. And just to remind people, this has been joined by the local authorities and the NHS, but has wider partners involved. Really important, part of the architecture that helps do what we've already touched on this morning, which is how do we bring different stakeholders together, in order to improve the health wellbeing of people in South Yorkshire. Focused on a number of things. So Christine's mentioned the work that we're doing collectively with the mayoralty and the local authorities in the work and health space. So trying to improve levels of economic activity, because we know that's a key enabler to good health. We received £18 million of additional central funding to support that work. So a really important opportunity to improve economic activity and thereby improve health. We had an update on the work we're doing collectively around increasing activity and encouraging people to be more active as part of the approach. We had an update on our focus on children and young people and the work that we're doing again collectively to try and ensure that children and young people have the best start in life. And just to highlight, we had an excellent event for South Yorkshire. The South Yorkshire it was a child poverty summit held in Sheffield, which was an incredible example, really, not only of how agencies work together, but also what was really powerful was listening to the voices of families themselves and how we need to get better at being guided by the voice of the people that we serve. There's lots of examples. So Neville's story and how that's being applied is one of them. The North East Neighbourhoods work in Sheffield, for example, where local people have had a good agency in that process. But increasingly, it's about how do we get better at listening and responding. I think the final thing we touched on was the government's white paper, which I mentioned in January. That does identify the potential for a legal duty for the mayoral combined authorities in the space of improving health. I mean, our own mayor in South Yorkshire has always been committed to that agenda, and actually South Yorkshire is name checking the white paper as a system that's perhaps pointing the way in terms of the national direction. But I think it's clearly important that we build on that. Just two final points. I gave a bit of an update in my paper about GP collective action, but really pleased to say that since writing the paper, we've seen a resolution of the concerns that have been raised and been subject to that national dispute. I think it's fair to say that's really pleasing to see that resolution being achieved and the national contract being supported by the BMA, the principal union. And it's been a number of years since we've been in that position, so I do think that's encouraging. I think it's fair to say that primary care are absolutely central to our aims in terms of improving people's health, tackling health inequalities. We've got to focus on the agenda later on primary care, but I think it's, the fact that national dispute has been put to rest, I think probably gives us space to think about all of the good stuff that we want to do collectively in order to support primary care and also for primary care to play its fullest part in the work that we need to do. Last thing is just to name check the winners of our Stars Award in January and February. So Ursula from our clinical education team in AHPs, and Helen, who works in the Doncaster CHC team, for her work supporting particularly young people with regards to their continuing healthcare needs. So just to say well done to Ursula and Helen, and I'll leave it there, Chair.
Karen, thank you. David, you want to?
Okay, so I suppose there's a couple of other changes on there. I think Aidan Ballard, who's the National Director for Patient Safety, he's going to CPC as well. So from the Samantha Pickard's resignation, we should acknowledge that, given that team. And then the final thing is for us as a board to be mindful. I think we're entering a pre-election period of sensitivity from the 24th of March because we've got local election.
Lisa.
Just a quick one on the GP collective action. It's just a reminder to people to still engage with their GPs. GPs aren't striking. It's nothing to do with that. It's business as usual. They still need to engage. Just because this is a meeting in public, still go to your GP, still make appointments. I think in Sarah's report, is there some feedback of the impact of the collective action? And I think so far it's been okay, hasn't it? So yeah, just wanted to mention.
Lisa, thank you for that. Okay, thank you. Questions from the public? Andy, there you are.
Yeah, we've got two contributions, Chair. The first question from Saeed Abrar, who's a third-party provider of AI software. He asked about the adoption of AI software for delivery of mental health care. We'll provide a full response to him about how we're working with partners, and Kieran supported that. The second question was from Minesh Parikh, and Minesh, a councillor in Sheffield, has asked a three-pronged question about how much we spend each year on providing community mental health services, what proportion of organisations are funded in South Yorkshire and outside, and what proportion of spending is specifically targeted to achieve better outcomes for Black, Asian and minority ethnic communities. And in essence, the answer is that we spend 120.8 million across South Yorkshire, and that includes talking therapies, community-based crisis services and such like. The majority of that is spent within South Yorkshire, and we're going to do some more digging to provide a really detailed split of what is in South Yorkshire and what's outside of it, but the vast majority will be here. And then the third element is that whilst we don't apportion community mental health services based on the diversity of the community, clearly through our integrated care partnership strategy, we are doing a lot of work to reduce health inequalities and improve access to mental health services, and that will support our diverse community. So the second element to say is that unfortunately, due to an administrative error, we did miss these questions in November. So just want to place on record an apology to the councillor for missing that, and we will write an apology to them based on that.
Right. And can I just have one other thing which I should have said earlier? When we reply back to these complaints, fine. Can we just make sure the board sees I've just looped into a copy? Give them a break. Thank you. Okay. Corporate risk, board assurance, corporate risk. Thanks. Mark.
So I'll take the report as read. I just want to. Firstly, the paper and the associated registers are presented for board assurance approval. There is a summary within the document of the review and series of oversight and scrutiny discussion that take place. You will note from the cover paper some of movements in mitigation. I think it is worth noting that the consistency of our principal risks, they remain very much the same and consistent, and consistent with many of the discussions on the agenda. In terms of as we move into 2026, the risk management team are undertaking a review of all of our registers at the moment, and just to ensure housekeeping and consistency, and an update for the financial year. And the final thing I would just flag is there is ongoing work, as indicated in the paper, across the system to look at the concept and methodology for capturing system risk, and we're engaged in conversations not only with risk leads, but also chairs of the audit committees, and also with input from the so as that unfolds, we'll update the board accordingly. And as part of that work, the risk team are also linking with our partner organisations within South Yorkshire, looking at how risk and learning how risk is managed within the NHS organisations in South Yorkshire, so we can maximise our own learning.
Well, thank you.
Yeah, just on the risk question, obviously we've got budget announcement, as we know, we've got coming up, and that's obviously going to impact, and they're aware of that. But when we talk about doing transformative work, I just wonder how they're connecting our risk register with, say, for example, the local authority, how they manage their risk. And it's about kind of populating that conversation around understanding. I'm just mindful that when things happen to us, it impacts the wider system. So it's not just about how we manage our risk, but are we kind of raising awareness? I'm sure that obviously they're aware in partnership conversations, system conversations, but I'm particularly interested in that space around risk and those conversations. Manage it, but how we should manage it.
Can I just add something that you might want to join? I think one of the things we've tried to do as an ICB is have a really good relationship with authorities, so we sit down regularly with chief execs and leaders around our issues and their issues. The last thing we want to do is create an issue for them by cost shifting or vice versa, by the way. That doesn't mean it's straightforward because the financial pressures local authorities are facing. Well, as one of the local authority leaders said to me, so finally you're in the same position we've been in for about 10 years. Because they've been facing this kind of pressure forever, it feels like. And so it's real, it's right to us, but we are trying to have really, really good relationships so that at least we're aware of where we are. It doesn't minimise the nature of the risk. Emma.
So as part of the place partnership, we have the risk register for the partnership, so we're constantly reviewing our risk as a system. You know, we're really trying to, that makes it really good. We, you know, we have a principle of trying not to caution, really understanding the impact of decision we make as organisations. And that feeds into that.
Yeah, I think it's not necessarily about apportioning risk management, it's more about actually how we're having those conversations, because when we then get into conversations around transformation and doing things differently, we have to do that quite fast and quite deep. Actually, we're responding to a lot of what's in our risk register and theirs. The question is, how are we then going to manage that process? So it's not necessarily a question about risk, it's about how.
I think it's a dynamic process. Yeah, constantly. It's absolutely constant. It's not something that we do, or even at a partnership board. It's constantly probably daily. I'm talking for example, you know, things come up all the time, so it's dynamic risk management. I think is where we're at. Really. Well, that's coming. Sorry, I'm going to check.
No, I think it's true. Yeah.
Just building upon these comments, Marks and Trees in particular, we're very careful not to enter the debate around the process. Relatively easy to do, and all we've heard thus far, and just today, is around that collective approach to managing services and offerings and things in Yorkshire. So it's required a lot of OD. I think it requires more than mindset, understanding, so when Mark talks about developing collective system understanding, it's more than just a concept. More than ever, looking at your chief or a lot of that is around partnership, those maybe with your so I'm urging more collective. All.
That's right. If you only listen to Neville's story and realise we cannot resolve health inequality issues from this problem. We actually have to work in partnership with a whole range of agencies to try to make a small difference. Thank you. People happy to accept Mark's report in respect to it? Mark, thank you. Agenda item 10, strategic update on the plan.
I'm straight over to
Yeah.
What I thought I could do was just come out some of the key points from the in terms of the National Year Health Plan, still expecting that to be with in May. We hosted a work event in South We've also submitted a climate contribution. So working with our partners, including Health Watch, we have supported our citizens that can in terms of contributing to that national consultation, and that's included
Since coming together, they have actually launched the next phase of the national NHS change process. So they're now seeking input from us around our priorities. So that might be helpful just to give you a bit of a flavour of what that
You say they, you mean public health NHS?
yeah, so
Sorry.
the next phase of NHS change conversations, so it's launched probably the last 10 days.
Okay.
And in there, what they're asking for is our contribution around priorities. And they've done that in a kind of a Q&A type approach, so there is an opportunity for a lot of recounts. But what they've done is they have, they're seeking input from individuals, so all of us, and we will kind of communicate them. Share them towards all members that will be communicating it through our channels with staff. And in there, what it gives you an opportunity to reflect is how you feel about things like healthy choices. It's got a focus around responsibility. Interestingly, it asks you to think about identifying what other parties in addition to NHS contribute to health and in their identifying authorities, BCC, education, etc. It has got a section around care delivery, and it asks you to think about how comfortable you might feel around seeing different types of healthcare professionals in different settings. So it talks about pharmacy, nurse, thinking about microinjuries, it talks about physio, intro, and it asks you a kind of options. There is also a section for staff, and in there, the kind of staff section is focused on how do people feel about staff having access to broader information so that they can actually have broader health conversations with the school. And then the other areas are focused on targeting. So it asks about how you feel about always more closely target our resources and whether the extent to which you future of the NHS, and how we feel about it. So that's a little bit of a flavour of what we see. The next bit of the paper really is about broadening over the focus a bit more on operational planning. The bit that I would pull out there is the expectation around us in terms of our joint form plan refresh. So we know that upon the publication of the National 10-Year Health Plan, there will be an expectation for us to do an extensive review of that. Ahead of that, they have people will do what they're describing as unlimited refresh. So our proposed approach for that is to refresh our forward, which will give us a bit of an opportunity to reflect on our progress, achievements, also gives an opportunity to kind of start to have think about how we articulate the challenges ahead, and set the tone in terms of the environment that we need to, and that we align the plan with the operational plan. So in essence, fundamentally, the plan remains as our plan, and it's very much in line with the weighted reshapes of the National Health Plan. So what we're doing is review. And the final part of the paper is really about the integrated and shared a little bit about that. One is that we have now completed our membership review. So we have got confirmed membership for our green boards, and we've also got our confirmed ICB membership, and that's really helped us strengthen that in the ICB, and also we've got wider partners. And we've got alongside the so in terms of recommendations, it's to know the very limited approach that we take in terms of interest, the light and the continued development of
When is the 10-year health plan due? I guess the real issue we're all facing this year, we're going to come on to this year, next year, is how do our aspirations and the aspirations that we in Darcy, technically haven't had the plan yet, fit with the financial pressure that we're facing today. I'm a cynic. There is a possibility that it was helpful to have the 10-year plan coming after the financial settlements and our plans and agreements. I think coming before might be very, very challenging for it. But it doesn't change the challenge that we've got. I think, we need to take a long hard look at that 10-year plan in the light of where we are. It's just more challenging to make those shifts for everybody. Finding the obvious needs.
Yes, I was sort of building on that. I mean, clearly the operating environment is very difficult, I guess, challenging from a financial perspective. But I think the value though of the joint forward plan is it does keep us true to the kind of the breadth of our aims. So it isn't just about the national access, improving access pressure. Of course, it's about those things, but it's also about our wider responsibilities in terms of improving population health, tackling health inequalities. So I think actually it's it's a really important framework so that we keep our shape. The danger is we just focus on some of the most immediate things. I think it's an important piece of work.
Maybe repeating what Gavin just said, I think the refresh plan is absolutely key to showing our ambition going forward. But we can't ignore the reality of what we already know. I think we're in danger of doing something quite superficial, recognising that word it took out your chief executive was prioritisation. And I think we owe to ourselves and the people of South Yorkshire to be very clear about the things we need to do first, which I think very dynamic actually apart. If we ignore that through the refresh, I think it's probably going to be something to ourselves. But the reality of what not only financially.
So I mean, just to come back on that, I think Kevin makes a really, really important point, and I talked about transformation and eliminating waste and duplication, but it is also about making some difficult choices around the range and scope of services that we offer, and if there isn't compelling evidence for a particular service, or it's something that's going to have a lesser impact in terms of the things that we're trying to deliver, then we'll need to make some choices to stop some things. I mean, clearly, if we're in that space, which we may well be, we need to follow due process in terms of who we engage and how we do that, who we involve, particularly the public. But I think that is the space that we're in, Kevin. I agree.
Thank you. Okay. Can we move on into the place partnership updates? Katie, you're the first one with volunteer. I suspect you haven't written this.
I haven't written this, but I have had a briefing.
Good.
So really pleased to be here. Day 3 for me. So please don't ask me any difficult questions, or if you feel I will take them away and endeavour to answer them. So a couple of points to pick out of this then. Just really pleased to report that the mental health crisis line, which we've been working on for some time, is now in implementation. And you'll see from the report that we're looking for the element of that's for children and young people to be up and running in April as well, which is significant for us, given some of the pressures we've got in Barnsley around that. We are continuing to work really hard across the provider landscape, obviously including health and social care. On some of the UD10s, we're still in a fairly pressurised situation. In the meeting yesterday, just about looking at the pressure on all front doors that are coming through, and how we work more collaboratively to move people through our services to the right place of care. We've got pressure in all bits of the system, which I know is no different to anywhere else in South Yorkshire, but a real focus on that and thinking through different actions that we might be able to potentially take to begin to reduce some of our non-elective activity. So a focus on that. The second page of the plan aligns with the mission and intentions, obviously, that we've got in place, and many of those are progressing as we would want them to, but the work and focus that we've got around obviously urgent emergency care flow is a key one for us. In terms of just things for the board to note, we are within Barnsley Council awaiting notification of our children's SEND understanding. And also our CPC inspections. I was highly grateful not to arrive in post on Monday. So that the CPC were coming to inspect our adult social care services, but that is also imminent. So lots of work going on across the patch just to make sure that we've got all the provisions in place around that. And then just loads of very, very positive feedback from a session that took place. Sadly, I wasn't able to go to, I was on leave, around neighbourhoods last week, and it's really ignited the volunteer partners about thinking through how do we do some of the provision on the ground and some of the stuff we were talking about in the first item actually. How do we do some of that in a really cohesive and consistent way? Making sure that we're consistent with South Yorkshire. So that's it for me, short and sweet.
Thanks, Doncaster.
Thank you. Katie hasn't got a memo from Wendy yet. There has to be an award somewhere.
I'll do that.
I'll be quick, Chair, because we've already heard how far Doncaster is. There's just a couple of things I wanted to mention. We had a great Get Yorkshire Moving network. We're at the forefront of some of the Sport England work on that. I'm not sure the video actually plays from the from the paper here, so I'll make sure that's circulated. But it was great for the mayor to open that conference and look at really raising the profile of what we're doing nationally around getting our residents moving in Doncaster. There's also another case study. It's Angela on this occasion around some of the benefits of our mental health navigators, and some data there that shows that partnership working between our mental health services and St. Leger Homes and Doncaster for residents. So I think that's a really powerful work. So the theme of primary care later on, we have a Doncaster health van in Doncaster about some of those more innovative ways of allowing our residents to access primary care. So this is very much a mobile service. If anybody ever wants to ride along, let me know, and we can organise that. Some of the statistics are there, but I think the most positive thing around this is of the 23 locations that the health van has gone to in the last quarter in Doncaster. They're some of our most deprived and underserved communities in Doncaster, and they're allowing residents to access things that they wouldn't have done so through the traditional method. The last two things I wanted to mention. Obviously, we've just seen our highest risk on our board assurance framework is around the estate at Doncaster Royal Infirmary, and that's well in this board. But we are now underway with the project and taking the investment around refurbishment and relocation of key services within the Royal Infirmary, which might want to add to this, but this is about reducing some of the risks that we've got on that estate, given the continued disappointments around no new hospital in Doncaster. I'm confident, Richard, that next time I come to this board, I'll be able to also update on some of the work we're doing around the relocation of services, both mental health and secondary care in Doncaster. And the final thing I wanted to mention, really, on the back of our board session last time, is some of the work that we're doing around anti-racism in Doncaster, recruitment, training, and the messages. And that again is multi-organisational. And thank you to Christine, who also joined me on the South Yorkshire Primary Care Race Equality Network last week, which again, to the theme of primary care, shows the work we're trying to tackle in terms of anti-racism.
Do you want to Richard on the capital?
I think Anthony's comments are accurate. We've recently started a £19-20 million scheme to build a new critical care unit that is a building block in terms of if capital becomes available in allowing us to refurbish the tower block. And as Anthony says, we've been working with partners at Place to learn from the award-winning Glassworks and Barnsley in terms of moving services into the communities, not in the sense of neighbourhoods per se in this aspect, but in the sense of town centre and town centre regeneration. The partners can make that work, then really, that is an opportunity perhaps to have services similar to the Glassworks scheme. I think have done a lot of things in terms of providing an environment that people can more easily get to, but also building on the regeneration of the city centre in a way that helps businesses and others directly. And I think actually that is really the sorts of things we can look at that would help our communities more so than potentially basing all of our services on the acute hospital side.
Yeah, that's true. Thank you very much. See, Katie, you might have a good number, but even Dom's got my mobile. Chris, do you want to talk about?
Yes, I'd be delighted to, Chair. Thank you. So just a lot in the report this time. So I'll just try and post it. Just on this other place direct to one of my duties of the economic value. They've approached this involvement as trying to maximise social value through procurement. The parties involved have spent 500 million. Also, we're trying to put in a process where we can actively track that and understand it. And our key role will be obviously to act as the driving supplier of commitments, but also then working suppliers to let them do the commitments as well. So social values a big thing for us. Next one is Bluebell. Bluebell was a children's hospice that serves South Yorkshire. It's actually based in Rotherham. It's not Rotherham. It has been closed for 24/7 services since 2022 due to workforce issues. Good news is here. Good news, great building. And in terms of building on our other priority, which is about the starting line, we've got a safe place to sleep initiative, we've got family homes across South Yorkshire. And in Rotherham, we've enhanced that by having baby packs, which is for all families. So we're hoping to issue 2,740 baby packs in the next year, which is every child in Rotherham, to ensure less starting line. And the next one, this isn't about, so we're co-located with the council with the site action in Rotherham. We started to try and get the benefits of co-location. And one of the teams I've managed to link closely into is the planning team. What we've worked now, we didn't really get full benefit out of the infrastructure levels. Working with planning colleagues now, particularly putting developers for the council, and they're being required to put infrastructure as well. Managed to get 5 surgeries getting upgrades as part of this, as part of the community infrastructure. I think that's something again, just an integration, co-location to see the benefits working. Last thing, so the big thing for me this year when I made my New Year's resolution as the place director, trying to how do we to influence emergency demand for urgent services top of my list. One of the things I'm doing is the review of community services, which I'm but the key thing at the moment is integrated services. We call it transfer of care. We've had an integrated discharge team for about 5 years, and that's the discharge team at the hospital. We're in a joint team with the social care team, and they work close together on discharge. But what we're looking now is to co-locate at Woodside, which is just like the hospital. So it'll be the integrated discharge team, including hospital and social care, for the community nurses, therapy services, it's Yorkshire ambulance service, the voluntary community sector, all be co-located together. All practitioners and the clinicians involved will be able to use that transfer hub as a source of advice for patients with emergency needs, hopefully prevent them to go into a UC. So that's the highlights, Chair.
Thank you. Any questions for Chris? Next question. Sheffield, Emma.
Yeah, I thought your New Year's resolution to wear long sleeve shirts. So yeah, thank you, Chair. So from a Sheffield perspective, obviously we've got 7 priorities as a place partnership, and I'll update you on 3. The first one is around same day urgent care model, and we agreed at our last place partnership direction of travel. One of the key things will be around the clinical assessment service. So actually, we have 21 entry points into UEC in Sheffield, and we're looking to develop a new clinical assessment service with Yorkshire ambulance service to try and streamline people into the right place. And building on that, we've got an expanded response service now to the care home. And again, we have the lowest conveyance in South Yorkshire of ambulance journeys, and we're doing some more with it, which is great. In terms of discharge, which is definitely one of ours, we're currently at 13.7%, which is absolutely fantastic. Probably the lowest we've seen, the lowest in South Yorkshire. And we've got half the number of patients on pathway 1, which is in December. So again, the transfer hub that we've introduced is really starting to play dividends
we're not out of the woods yet, I hate to say that, but we are able to close some of the surgery beds. So I think you can see it's that continued improvement in that area. So I'm really sort of proud of the work that my team have done along the local authority and SCHP in that space, because it is going to be. And we have a new information pack launch. There's plenty of backs upstairs. Not one in Wall Street, so it's not far through. But again, we developed a great information pack for patients with some documentation around that. In terms of the Sheffield team, we had our healthcare partnership board weeks ago where we're looking at our commission intention. And basically, we've got 7 priorities, and we've still got 10 priorities, but we've changed one around medicine optimisation to end of life and frailty, and we've expanded our neighbourhood working. So we've got our community programme around the North East, but we're actually introducing integrated neighbourhood teams more about from the medical side. So actually, how do we sort of coalesce community and their strength alongside a neighbourhood model? And we're working. Obviously, we had an event last week which we were part of, and we've got some great clinical leadership from Sheffield around some model neighbourhood and integrated neighbourhood teams. That's how it's happened. And I've just been successful based on the NHS Confederation of Community Learning Practice, which I'll be participating in, trying to get welfare in the country, bring that back into Sheffield, which is great. But I think what we're saying in Sheffield is we need to kind of stick to this thing. We're not in the process of having loads of different things. We're very much focused on what we're doing, because what we need to, and as Chris has said, is actually transfer and have some radical place leadership in, I suppose, primary community and large sector. How do we start to transfer resources to that area, which is what Karen talked about before, and how we're going to prioritise those decisions, as you said, Kevin. How do we start to make that real? Because we've talked about it for 20 days for years, and we're just not able to do it. So how are we going to do that flexibly as a partnership, particularly working with our key partner in the local authority? So I think that's where we are with that. And the neighbourhood, the North East model is a small grant celebration, and you can see some of the impact, some of the work, some of the grants that are happening. It's absolutely the right thing to do. And again, how do we make sure we can test some of the work we're doing and spread it across other places in Sheffield? And then there's some partnership issues there which I want to touch on. And as I say, major focus for us on the money, really, prioritisation of resources and really kind of sticking to those priorities. A couple of other things just to mention is that STEM, we're currently in the process of having a STEM inspection alongside Sheffield City Council, and also we're doing a lot of work on our primary care estate, and I'll bring a full update to the next meeting on that in terms of where we are. So we have major progress, but the board needs to be started on that. So thank you.
I think it would be really helpful to do that. Yeah. So thank you. Any other questions from that? Thank you. We're 10 minutes ahead of time, so we're going to take. Oh, Kevin. Well, we might not be 10 minutes ahead.
What's the question about particular? I really enjoy what they do is show the character, personality of each of the players, which is important. What sort of stimulates what I'm about to say? A couple of places mentioned neighbourhoods. Yeah. And I wouldn't really want to change the construct of it. But could we start to think about maybe every time we receive places, every time we had a sort of theme built into it? So that, so I think you sparked my thinking. What's the model in Barnes which shows essence of self? Because the question I was, I just wonder what's happening. This keep everything up to change. And then we talk about how we share and how we
I think that's really helpful, but there's a bigger issue there with what's going on around there. Maybe we need that as a topic that the places play into, because there's a lot of thinking going on. So maybe as it's an agenda item, it's all right. In addition to the partnership, because I think there's whether there's a conference. I'll speak on this week.
I'm happy with just share a couple of questions on.
Yeah, I can do that now. It is part of the. Yeah, no, it is part of the update later on. But this time last week we did have an integrated neighbourhood workshop across South Yorkshire. Thank you to people in this room who were either there or inputted into that as part of the development of that. Kevin, it's an interesting mix between us as a South Yorkshire system giving momentum to that agenda. It comes out very heavily in the planning framework. It's not something that we've just discovered. This is really at the forefront of the work we're doing anyway. So how we give momentum to that, whilst recognising the unique nature of each of our neighbourhoods within the places, and how we found that sweet spot of that to really drive this along. I found a lot of energy in that room, big to organising, and now it's how we build on that momentum to put this right at the fore. I'd be happy to come back and do a section.
Whether we do it in formal or something, it's a theme that's gonna. It's in the plan. It's in Darcy. We should actually have a conversation. What's going on? That doesn't mean it's the same everywhere else, but I think it's over and above the place-based stuff. That's all. Lee.
Apologies, Piers. I was thinking when I said in terms of the place reports, they've seen we now got into a space now. There's a narration of good stuff, which I think is really. I was just thinking though about the challenge for next year and sort of links to the IPR, and if we really do justice to how well we're delivering our plans in place, how that might link to an emergent approach overseas. We perhaps need to systematise through the place reports what the current operational and financial reporting challenge is in a bit more explicit way. And we put that in the IPR. But if you look at the juxtaposition between what we've got in the IPR and what we've got now in the place reports, should we do a little bit of thinking on the executive side of the street about how we bring that together? I'm not saying they're wrong. I'm just saying we perhaps need to think through how would we be able to over the support? We've got really good oversight about our place plans and how we can live with them. And I think we need to give that a bit more consideration. And it probably starts with the scrutiny that we give it.
I agree. And I mean, there is a risk if we're not careful. You know, we're going into the most challenging financial year I've experienced, and we can't have a place plan that look at what's happening. Yeah, we know it's really. There are real challenges at place, and our plans need to reflect that, and our full support needs to decide how we go. And there's no right answer, by the way. We just need to be explicit.
So we do. So we have 4 places.
Yeah, I see that it's.
Well, I wouldn't want to job in place. I
couldn't agree more. I couldn't agree more. That's absolutely right, but it's not our job. It is our job, though, to have people reflect. It's that balance.
So I just wanted to, I mean, I think one of the things we agreed was that there would be a kind of theme that would run through the reports, but I think the point I want to make now is if you look at, there's lots of good stuff here, but it's not just random good stuff. I think there's something about making explicit the connection between, improving services in the community to avoid unnecessary admission into secondary care. These are programs that are helping us with that. So I think some of this is about making a connection as well as achieving, I think, the balance that you quite made.
Okay. That was a helpful information, We've got a 10-minute break, so we'll come back at 5 by that clock, not by your clock, by that one. Okay? Because the one nearest the chair. And a bit like the British Empire, they settled on where time is. I'm doing that today. 5 past by that clock, we're back in. They've got the lower go through. Thank you. Agenda item 12. We got forms to get. Sarah, you leading us through that?
So in terms of the IPR then, we had a conversation about the quality of training. We have expanded that and did quality. And we have tried to put more place in terms of the narrative to try and make the links. So any comments on that would be welcome. The third question I had last time was about the comparative data to other systems. We've done a piece of work looking at the NHS parking, what it does come at cost. So we just need to work through whether we're getting cost benefit. So I've taken those comments on board.
In terms, we've decided I'll go first with the operational. Then Christine will do workforce, and then Kathy and David will come in on the quality, if that's okay, Chair.
That's great.
So I will just do the operational, then, assuming the report being read. In terms of our emergency department performance, then we delivered 68.8% against the January, against the 78% standard in January before hours. That was on the back of a challenging winter, which I think we're now just starting to see we're starting to move into spring. February was similarly challenged, where I think we'll end the month at about 70%. But actually, the big focus in the ED world is around March and how do we exit the year as high as possible to springboard into next year. So there is a challenge to get to 78% in March. All organisations have produced an action plan to deliver that. It's been highly monitored by colleagues in NHS, and we're currently working through that. Just to put it in context, we're only a couple of days in, but we're already at 75% for the first few days of March. So people have put significant effort into exiting winter, getting into spring, and improving the performance in the ED department. In terms of ambulance, then, again, we continue to work through that. We're about the 30 minute standard, which is what we would need to be in next year's planning for category 2. And we are working, and we had the second visit from NHS Sheffield Teaching Hospital. We talked about Doncaster last time. We visited Sheffield this month with NHS colleagues looking at their emergency processes, and there are fortnightly meetings in now to look at how we adopt the 45 minutes within the Sheffield patch. So quite a significant piece of work in the UEC world. In terms of cancer, cancer is the thing that troubles me the most, if you like, in terms of our performance in South Yorkshire. We do continue to deliver on the MDS standard, so 81% of patients knew their cancer diagnosis before 28 days, or knew they were ruled out within 28 days. But treatment within 62 days, we have seen an improvement in performance. There was a significant step we've read the reports, 70% in December. But we need to be cautious of that, because we do less treatments in December, the backlog has gone up. So actually, yes, we've seen an improvement in performance, but the backlog's got bigger. So we've started the year in a worse position. So that will continue to challenge us through January, February. We all know we're in tier 1 performance with NHS. Clearly, it's not had the impact that it was meant to. They've been in tier 1 certainly longer than I've been in the ICB. So we had a meeting in July and NHS to look at how we refocus that meeting, become more pathway specific, and how we become more clinically focused in those meetings to get some more energy behind delivering. It will be a challenge with the workforce issues in STH. In terms of elective, again, you've got the figures in the patch, but with regards to the 65-week backlog, again, the biggest challenge is to how do we exit the year and how do we be judged against other organisations. As it stands at the moment, there's been a significant improvement in Sheffield Teaching. They've got insourcing in, and they expect to end the year with less than 100 patients. I think they'll end up with about 60% of patients waiting over 65 weeks, which is a significant improvement to where we were just before Christmas. So significant effort gone in there. Sheffield Children's Hospital, however, is having challenges with specialists in orthopaedic and urology. So I think they will end the year with about 50 patients waiting for over 60 weeks. Doncaster, again, continues to work on it. It has 2 challenges, one in ENT and orthopaedics. Made significant improvement in orthopaedics, and is currently working with independent sector providers to look at the orthopaedic backlog, to say that right through. I think that I'm feeling like we met with the trust on Friday. They gave a range of probably somewhere between 50 and 250. My book says it's probably going to be about 150. So I expect to end the year with about 220. And I don't know yet how that will compare with the organisation across the system. So we'll get
information. The other bit in terms of mental health there, you can see in the report our out of area placements have gone up specifically in Sheffield Health and Social Care. There's work going on with delayed transfers of care and how we bring up those beds across the system. So significant work going on at place and through the mental health collaborative to look at how we reduce that reliance on out of area placements. And in terms of primary care, we've got the primary care report later on, so I won't know too much about that. GP collective action, you made reference to the fact that yes, it's still ongoing and we still don't know what it really means for week, but within South Yorkshire, the impact may have had some ripples, but it has been relatively minor compared to other parts of the country. I could just stop there at that point and take any questions.
Any questions? Well,
It's a comment actually for you.
yeah, please do.
About learning disability. It's a really helpful piece in the report, I think, and across South Yorkshire, we've done a fantastic work on learning disability, physical health check for people with learning disability over the last few years. It's not a national metric next year, but it can make a real difference to people's lives. So it'd be one thing I really ask us to keep focusing on. And also the fact that we are increasing the number of people with autism being looked after in person is increasing. That is not always the right place for people to be looked after. So again, I'll just have to keep our focus on that.
Laura.
In mental health and an update on what we might be trying to do on the side to address that. You know, it's about more investment, more capital investment, great support.
There is quite a detailed action plan that runs through the council line, so absolutely I think we can get that in.
Yeah, the mental health group have been doing some work. Why don't we get them to come and talk to us? They really value, the mental health plans really value to them. Lisa.
Thank you, Sarah. I'm just having a look at the placeholder for the ADHD and autistic spectrum disease waiting list. Do you know when we'll have that data?
Yeah. So, well, the mental health collaborative have been working through that. What they've said to me is they've got data now, the data quality is poor, and they have promised me by April. That's what they've committed to, so that's what I'm going to.
So I know on the ground as a GP, that's a big,
it is. It's a really big issue.
So how do you pick up? So if I look at, I can check I've got this right.
Yeah.
I look at where, and now we don't have all the comparative information, but we look most exposed to the over 65 week weights. Is that right? That's Sheffield Teaching and at Doncaster.
So I think we're exposed to cancer. We are the worst performing cancer line across the country, and that is predominantly teenage. And I think in 65 weeks, we're probably bottom of the third quartile, so we're below halfway, but we're not.
So the cancer is the one
cancer
really poorer than everybody else. I just need to hope the board understand that. I wouldn't want this meeting to finish and think it's all okay, because the answer is it isn't. Greg, and
just picking up cancer, stupid newbies question. Why is that a sort of big specialist centre issue? Is it the same in Leeds? Is it the same in Newcastle, etc.?
It's similar, but not to the same extent. So I think we've got workforce issues. I think we had some process issues where we've just invested in significantly most organisations, cancer navigators, to help patients basically get them through the system quickly. Sheffield will probably slow to adopt that. I think that will have an impact. Workforce is a particular challenge for us. I think the planning for Sheffield Teaching has turned over, there is more, they've done more detailed work. I think they think the problem is actually bigger than they thought, not smaller than they thought when they gone through their plan. So I think there's more to come in terms of that.
it isn't a teaching centre group, but everyone's got a teaching centre. You think it looks the worst. It's
You can say that we've had an update. When we've worked on boards of- so, you know, and I don't know whether you do that in the board meeting, so whether that can be helpful in this conversation, because it used to be more time and space to understand what's going on. Because
Yeah,
and
this
helpful
is
to know.
it's raising as well. So the last council I for Kirsten and I agreed to take it. Kirsten is the chair of the council alliance. It's happened to come here and bring myself and talk to the board. Just need to go for it.
Yeah, can we just think the best way to, I agree, we can debate whether to do that session or not.
I think it's so important. Probably from here to
I think that's really helpful. Get it on next formal board meeting.
So it's can't really put down. We have agreed, in case agreed to come with me to chat.
It is, that's great.
Thank you, Chair. It's not council related, and apologies, it might be this question will be different around the number of patients or children in the to keep the same question. My concern is we've been watching this growing over the past 6 months. What I accept as collective and taking into account there might be elected integrity. Nevertheless, the growth that we've observed seems to be a sense of urgency. So, that's one of the bottom line. You're going to be worried if there is 7,000 children subject to data quality waiting over 2 weeks.
So all of those, well, I think there are about 10 or 15 of those patients with ADHD, yeah, they're all ADHD. Sheffield Children's Hospital is the only place that I can find that actually reports it nationally. Everybody else, because it's in mental health, don't actually report it. So it is a hidden problem across the system. Certainly the work that's being done in Sheffield about so it's not something that's being ignored. If you ask Sheffield Children's Hospital, this issue, it would be that one. And certainly the work that's made to that in terms of how they're tackling it.
Yeah, I mean, there's a massive piece of work been going on for 12, 18 months around the autism and the ADHD waiting. So we've had some discussions about our place partnership, but it's not ready. We're not quite ready to launch it, but it will hopefully have a real impact on pathways, and obviously we'll bring that to the board. But it is on, it's one of our 7
priorities. Really help. It's a big number, isn't it? So congratulate Sheffield Children on top of the fact they know there's a problem. Does that mean there may be a problem in our dash mother?
Absolutely.
It's a national problem. Yeah. Get that in terms of technicality. There's a minimum of 7,000 children.
Yeah,
and I certainly not assuming.
It's just, I mean, just say, I mean, one, there's a lot of focus on this nationally because it's a major problem. And I think the issue of counting and knowing the scale of the problem is part of it. But again, there's work happening to try and, it's surface the scale of the challenge. I think in South Yorkshire, I think there's a piece of work we're doing jointly with the local authority. There's an overlap in terms of particularly education and obviously the assessment that's delivered by health. There's also a focus on the health pathway itself, because again, there's a heavy reliance on I suppose what I would describe as kind of over medicalisation of the pathway. So I think it's something we could do quite differently. We are working on that across South Yorkshire, but I'm conscious that in each of the places as well, there's really focused work in Sheffield. So I just wonder whether, I mean, we just added quite a bunch of stuff on the agenda, but I think this could also warrant a bit of a deep dive, just so at least people can be assured that there is work being done, but it is a knotty problem.
Narrative. In the absence of very clearly for a lot happened.
Okay, that's all. Thanks.
Yeah, I'm just building on Gavin's point. I think it'd be helpful maybe to bring an update on what's happening with our send board, say like an ICB send board, partnership send board, but actually material work that's going on from a local authority relation to principles of like this. Each of the places developed models in relation to their partnership around how we unite class to the model and immediately, and actually that has developed significantly from the places involved in the Doncaster particularly. So I think it is maybe bringing it back, and that we will be reporting that through the send forward reports through quickly, Kevin. So hopefully you'll start to see that.
That's helpful. I mean, I think we need to think out offline of how to bring some of this back to the board, because the visibility obviously is really important. I think one about Sarah.
Yeah, just to Mark's point about not losing focus, and I can't quite comprehend in my brain. GP collective action, and it's the announcement this week that GPs are going to have to report less. Doesn't mean we don't want to stop the work, and we're going to have to be very careful and very select, given the context in which we work, about what scale of the challenge and what we can and can't deliver. Not that all of it isn't worthy of doing, but actually, I think the government has done really well with taking the shackles off us. But then our own internal expectations are that we're going to deliver everything. So there's something about how we balance that going forward. I'll stop there and I'll hand over to Christine just to
Workforce.
Yeah, thank you. Just in terms of workforce, these are main revenue numbers, just so that you're aware. We were showing that substantive workforce were over plan by 2%. Sickness absence over 12 months has remained between 5.6 and 5.7%. This equates to about 2,500 full-time, because just to put it into the context of actual people or roles. And that is much higher still than pre-COVID levels. So it's about 1%, which is around 400 people in 2019. And sickness absence levels vary across trust. The highest sickness absence Sheffield Health and Social Care. And we are engaging there with colleagues around the region, because in particular Humber and North Yorkshire have quite low levels of sickness absence generally, so we are working with them to try and understand what are the drivers and what are they doing to bring down sickness absence, because that is a driver of our temporary agency spend as well. Just to note that in terms of cost of temporary workers, well, the cost and use of temporary workers, we have it still remains high, still remains over plan. We have done a lot of work to try and reduce the number of agency workers. That has seen an increase in bank workers, but the costs still remain high. So we're trying to understand whether the shift of that is, are we using the bank to cover particular different roles or higher spend areas, because the pay bill, whilst the numbers are going down, the pay bill is still. So I think in summary, there's a huge amount of work happening in the space of temporary workforce. That translates into the planning guidance for this year. So there's a real challenge for us around that. So we've got to really continue the work that we started with the drivers of deficit work, and understanding the drivers of that contingent usage to try and resolve that here. So that is the focus of the work that we're taking forward.
So just coming on three things, if I may. So picking up the performance in UEC, emergency care, obviously we still continue to see pressure on particular days. We manage that risk through the System Control Coordination Centre. They say there have been a couple of incidents that happened, and they get reported and reviewed, and actually this afternoon I joined with ICB Gaz Oversight Group, which is where we discussed that in more detail. National Paediatric Cardiology hearing services, and we continue to oversee that. I'm the executive for that. So following two site visits to two of our providers, we're following that up with the other four providers. We've got some site visits that we need to undertake by the end of March. They all have improvement plans in place. We continue to work through that, and where necessary, we are doing harm reviews as well, which the deadline for that is the end of March as well. And the main risks that we've been capturing here, they are captured on our back, our risk in our issues log, and we report them through our system quality group, regional quality group. That we've got a number of items suppose on a slightly different slant, we've got some population health details in the report as well. It's good to we have made some inroads into smoking prevalence. I think that was definitely a priority and something we felt committed to as a board. School readiness, some glimmers of hope of improvement there, and some gaps with employment rates. But there are still challenges in regards to economic connectivity, so it absolutely supports the Pathfinder and Trailblazer programs that we've got in place. Finally, on that, I think we've recognised before that cardiovascular disease is our single biggest cause of death and disability, and that continues to be a priority. And hearing about the GP contract, that has been bolstered, so some of the money has been recycled into a greater emphasis on that. Those are the main things for me to pick up.
Yeah, so just areas for me, so from a maternity point of view, just to note for the board that although the data looks like it's 6 months out of date, that's because it's nationally validated data. So through the LMNS, Richard, who's our SRO, we both see more near-time data in relation to stillbirth, neonatal mortality, and preterm birth rates, as well as a whole load of other measures. So I do know that our numbers are better in this in relation to kind of stillbirth rates. We're working very collectively across the system, across all of our units. I'm not going to repeat everything that's in the narrative in the IPR. We've done some significant deep dives over the last 6 months in relation to the data around stillbirth births in a small number of our units, and there has been no kind of key factors found in relation to already know. So kind of needed to do that really concentrated work around mental health, but we can see the access to paramedical training mental health services is improving, so that's really important. Deprivation and then obesity, which brings increased risks to sort of pregnancy, and I think we've kind of touched on that challenge around deprivation and that challenge getting worse from an authority perspective across the whole conversation this morning. All of our trust of we just signed up there. I think we're in year 6. I always get confused, which is whether we're into year 6 or year 7. NFP scheme for trust, which is focused on patient safety and improvements. So all of our trust of the threshold for that. We just last week completed our annual assurance visits to each of our units, which is a multidisciplinary visit with the maternity and neonates this year. It's been a really helpful space. We're doing a peer review as part of that process, and I've talked on all of the visits around even visits for 3 years now. You can really see the improvement across all of the work that our units are doing. We've had huge improvements in maternity and midwifery vacancies, so we've got hardly got any vacancies in our maternity services across all of our units. We've worked really collectively together to do joint recruitment processes for the last 3 years, and we're retaining our midwife, which is another really thing we're doing. Important emphasis we put into that. But what that does mean is that we're able to focus those midwives on the enhanced opportunity care model or our vulnerabilities teams as they're called in some of the places to really focus on working with women and birthing people that find it more difficult to interact with. You know, over time, hopefully that will bear out some of that women and children, heavily supported by the Bernardo's work in the kind of medical information. I think just the example that Chris was is really critical, and certainly from a smoking perspective, which I've been stopping smoking. David's already touched on that improvement generally. We continue to see a real improvement in getting women to stop smoking during pregnancy, and then the family hospitals supporting that approach in sort of continuing that. Do you want me to pause? Maybe intent to that. Just want to do the two areas. So also picking up from other areas from a policy perspective. I'm not getting words out today. We have got from an oversight perspective, we've got Doncaster regional team in a sort of more enhanced surveillance perspective across delivering the CQC action plan, which we're making great progress around paediatric cardiology and sort of improvement supportive approach to helping it some of those more challenged spaces. From a safety indicators perspective, we've now got data in here which is really helpful and will evolve. So from a friends and family test perspective, kind of those key areas or challenges that fall out of that in relation to where we might be different from other systems. If I'm honest, and we're doing a really close piece of work with data from the engagement team in relation to how we really pull together experience around services across the system from all of the different access and information points that we've got. And this workshop being planned the next few weeks that will bring colleagues from the ICB really look at how we have a plate approach to that. The case is great work in that space and supporting us with that. Some of the patient safety indicators around quality, you'll see from a whole perspective, see the pressure and ulcers. The Chief Nurses and the Acute Federation are working collectively together around patient safety strategy to really focus on some of those areas. I'm not surprised by the rates, etc., because if you don't like that, it's overcrowded, A&Es, temporary escalation spaces, and the challenge to ensure really good cleaning of this state when you've got such challenged pathways. I'm not surprised by that. There is a collective piece of work across the providers in that space. Patient safety and strategy, we've got that developed for the ICB. That's going to quickly next week alongside our quality oversight framework that we've been developing as part of our patient design work over the last 12 months. And today we're holding a patient safety and community practice workshop with provider colleagues across the system in Sheffield to really look at what might be our priorities to work together and how we really start to share some of that learning. So those are the key things, Chair.
Fantastic. So did you want to come in?
Two things. Thank you, Kathy. And the skill of the thing, we know what to do. Smoking, spray, all that, not doing the right thing. It's the harder, work, to be honest. Safely, just doing dull stuff year after year after year. So we know what to do about doing that. You mentioned pregnancy and mental health. I don't know if this is a Sheffield broker thing, but some of our amazingness is very perilously funded. Very urgent behind the scenes work to fix that. On just very other critical PC, community PC, much messier, much harder. And I suspect there's a lot more volume wise, there's a lot more risk there. And there's some work to do to collectively shore that up. Again, the particular issue with Sheffield, it may be wider, I don't know, but it's on my screen now.
Any other?
Just in relation to mental health and maternity, we know that both of those are areas where there's huge inequalities in terms of ethnicity and race, but we don't get any kind of data in this performance report that helps us understand what's happening for different groups, particularly. There's no corporate section for that. So is that something that we're working on?
So we can pull that through to we do have that data and information, and we've done some focus work based on using the old word serious incidents in relation to what groups that have been affected. Most of the work that falls out of that is built into the priorities around the NFT plan, which we have brought an update forward on the last 2 years. We're bringing that, we read an annual report on that, but we can certainly work with Sarah to look at what we have hundreds of indicators around maternity. So actually what might be the best place to bring through, we've actually worked with Barbara and Sarah's team.
I suspect the question, which is how much we've got it, where do we bring it now? We can share it even if we don't necessarily bring it here.
Yeah.
Great. Kevin, and then
Okay, just one, it's more like an observation on the SHIMIC score, the summary hospital mortality indicator. I know from my own experience, do not automatically translate these numbers into a safety issue. I know that because the numbers are standing out. I know the work's been led by David and Kathy, which is really a simple question, when might we see the product of that potentially quickly, so that you understand the cause of this thing. The cause may or may not be.
do you want to respond to that, David, and I'll come back to just briefly.
So it is cited and it's used as a comparator. I think I've been clear, and I think most people would accept that Shimmy is kind of an identifier to say you might want to look at this rather than a quality indicator. In particular for Doncaster, who is a highlighter, there's a difference between the two sites. I know internally there's a lot of work to review the Bassetlaw site where this is driven by. We pick it up through the regional mortality group as well. It's going to be more complicated because we're going to change the way it's recorded. So there is going to be a stepwise change. So comparing historical data with what's going to be presented from spring onwards, it's going to be more tricky. So I think we note it here. I think we note that there's work ongoing. But I would say, as the Chief Medical Officer, I don't think it's an area that we need to get concerned about.
Lisa, then Sarah, Lisa.
Okay, thank you. I'm glad we've got that data, and I do think it needs to come here, or it needs to be in the public domain. I think there are communities and people who choose not to have children because they're afraid of the system that should be there for them. So I think if things are improving, we need to share that with the public so that they can see all the good work that's happening. As Kathy has said, there's been a lot of progress, and we're retaining our midwives, which has made a big difference to our workforce, and that will translate to patient care. So it would be good to have those numbers and to see those outcomes improve. And I do think we need to share them.
Yes, thanks, Sarah.
Just a brief point to come back to Greg. The eagle-eyed of you will see on the quality total number doesn't add up to the actual numbers in the hospital. The difference is the community acquired one, so we can add up. Because you will see on things like E. coli, there was less than 50 in the hospitals, but actually we had 108 as assistants, so that just to draw out that differentiation.
Thank you for that. Jennifer Rice from 13th Specialist Commissioning. Lee, is this yourself?
It is, Stephen, I think. So, bit of background first. Worth noting that the ICBs in 3 out of 7 of the English regions took responsibility for this portfolio of services on the 1st of April 2024. And we made the decision as the ICBs in North East Yorkshire, we weren't planning to do this yet. So it's just worth noting that. So there's 4 out of 7 of the English regions that still got out the commission responsible for transfer from NHS England to the ICBs for the 84 services described in the delegation. So we're seeing that. We've been working across the 4 ICBs and the regions NHS as well. And I claim a lot of work has gone on in that space, just about understanding the work program, specialist commissioning, understanding how to do that hosting, understanding how the joint committee arrangements will work associated with the receipt of this. And there is a current team who are discharging the responsibilities for doing this commission work at the moment. And the difficult bit has been actually mapping which bit of that team will do the retained services, not every flowing to us, somebody's being retained at the regional and national level, and which bits of it are coming to us, therefore which staff are transferred. So the staff which will be hosted in South Yorkshire will transfer on the 1st of July, but the proposal is that we will take responsibility for these services on the 1st of April. I don't think that transition is a huge problem in and of itself. The existing team will carry on with the services, and we will be receiving the staff on the 1st of July. And this paper here is to support the delegation process. The board will be reminded, I've previously described some risks with managing associated with the process. There's the risks associated with how do we manage well how do we do the oversight of the existing services well under these new arrangements. I think that's described now quite well through the joint committee arrangements and the ICB, the Four ICB teams have managed to get together to describe how to do that. It's managing the transfer, which are well described in terms of the pre-delegation checklists and the things we need to do technically to make sure we're landing safely. The bit that we're still kind of grappling with a bit is just the further is going to describe about how will we achieve benefit delegation. There's quite a big conversation going on about what's the change plan for next year and where do we have opportunities associated with the existing services versus the connectedness with these services with the things that we're already commissioned as ICB. So I genuinely think it's an overreached report plans. We're the first integrated care board in North East Yorkshire Family Conversation, so the ink is still wet, slightly moving about on all the documentation that I need to deliver across the four ICBs and the regional team, but it's here to note the updated progress, hopefully support the next steps associated with the delegation and us taking responsibility for these first April. But particularly, we now need to get into a slightly more technocratic mode about signing on the delegation agreement and arranging things, which I'm not intending to bring back here unless they materially change some things. But happy to take questions. I know we've had 1 or 2 years of this, but there will still be challenges and issues, I'm sure, but I think we're in a better place than once we were.
Yeah, thanks, Dean. So just to clarify, so we take on full responsibility for today for 2025.
Yes.
So we have got a period where it's good.
Which has been crafted in this delegation. In my humble opinion, slightly overcrafted. That period will be over the link, but I was hawkish. Colleague ICBs have noted that there's a bit of discontinuity between the staff providing those. Yes,
but I've got Christina, I've got more. Christina.
Thanks, Lee. I mean, I think the paper just shows how complex this is and how well it's coming together, though. I mean, I think it really just set that out. So thanks for that. There's just one remaining question for me, though, around our hosting responsibility and whether that has been factored into the conversation. I'm particularly thinking about the impact on our enabling teams of HR, finance, and so on. Because more staff, more work.
There's no. We've done something of the oversight of this in terms of finance, HR, other things. Just about the element of work required in here about candidly, if you just go about and keep the same stuff, transfer instance, quite some strong OD work required, both within the four ICBs and within the regional. What does this equal? I think Christine will be. I'm a bit more remote with it in terms of finances, in terms of finance stuff. But I think if we get into this material OD plan, a lot of conversation with the three ICBs to go, how are we going to resource that? Because I just don't think it's fair to just go, well, South Yorkshire HR function could run a program that requires 5 people because you don't have those 5 people. So
we have 2.6 full-time community. That's what. That's where my worry lies.
Yeah. Okay. Got Greg, Mark, and then Ken.
Very quickly, I don't agree with Christine. It's really, really well set out and very clear. I agree with this a bit. It's stupid, very parochial questions. Public health. Where does the spec on public health type land? I.e., you won't be expecting me to do it because it's way too specialist to me. I've not had that conversation. Cool. I couldn't see it. I don't think that's all allegation. They're not. Would they stay with NHS?
I mean, a large part of the public health assessment stuff is done nationally.
Yeah,
and then it's kind of received in the regional work programme. I'll go and find out.
Okay, I've got Mark, Kevin, and then Dave.
Okay, and apologies for the present, but if this isn't going to come back to the materials, I just want to tease 3 things out, particularly for the minutes of the board to absolutely approve. So the first is that the board is absolutely approving entering into the delegation agreement with NHS. Associated with that. The second is that because it's reserved to the board to approve the operating model of the organisation, I suggest it would be useful to know that transfer. So, I think it's the board on the committee with the 3 ICBs.
I agree. It's really helpful. That's what we're going. That's what we're asking the board. Let's go back to that. Let's go back to question Kevin and then David. Yeah.
Not necessarily a question, but very helpful. The before ICB or the committee chair at the end of January, the second time we met.
Yep.
So hopefully give you that level of assurance or not. I've overseen this exercise framed in 3 areas. One was the transition to new governance. I think we've received a good level of assurance, detail and that report supported by your leaders. The key there is just place the mark on the joint committee being formed. It's very limited voting. That's the view of the vote. How does that integrate with our own governance? Good level of assurance for all of the 4 ICB. The second bit was what's the inheritance? And certainly what we have seen abroad, really good exposition of the key risks from each of those services. And I would commend that information going into one of our assurance committees probably quickly, because it's very insightful. And then to the question of what to do with that, so very interesting. All right. The third bit, which makes a critical point, pertinent to Yorkshire, is we're hosting it, subject to the decision. What are the risks of those? There is something called a collaboration agreement, which is not in the packet. That is like quite critical to understand it. That we're not left with the burden of carrying the whole sense of what those risks and benefits share. The biggest risk is still from the way the transition from the staff in South Yorkshire, and the way that change process at the moment, and the same plan with those individuals comfortably into the organization. All the rest of it. But generally, a good level.
Really helpful. Kevin, I knew you were around, and that's really helpful. David.
I was going to respond to Greg in public health and from my perspective. It's the change for as it was first laid out. I don't think we've got a choice in it, Piers. I think there's no expectation to do it. So I think there's a number of things to be worked through from HR, from I think quality, we've got one system contribute tomorrow. So there are things we will need to work through on this. But as I said, I think as a board, we need to support Lee and others who are continuing to us to kind of make it work. Because as I said, I don't think it's necessarily a choice.
We delayed it a year, let's be clear. That's what we did. This is really helpful conversation. And people happy to support that move with the recommendation. Thank you, Mark. Thank you. Primary care delegation, another delegate.
Heavily trailed this report. Aiming to do 2 things. First of all, we're required as a board to update and that is within the report there. And secondly, this is an intent to give a state of the nation, if you like, situation in South York in terms of its broadest possible sense, including our 4 contractor groups. In an effort, I apologise in some way for the length of this report. It's a difficult thing to actually translate, given the 700 and odd contracts that we have across primary care. What I tried to do is a number of things, but including trying to promote some of the great work that we're doing. In an effort to translate that, I have a couple of slides. I know I have 45 minutes for this agenda item. So I'll quickly.
We had a conversation earlier about how long we had. He said 45, I said 1.
So we'll split the difference more widely. So Caroline, you're going to help drive there, aren't you? So I just wanted to cover the contracting groups and particularly note some of the great achievements over this last year in South Yorkshire. The first thing that I wanted to pull out is that we are starting to get some significant improvements in practices reporting patient experience and access through all our focus on modern general practice. Now, this is not, we still hear, don't we, from our residents that they have issues trying to get through to their practice and indeed to access it. But we are starting to see, green shoots in that area. And you'll see from the report that Sarah produced earlier, the amount of appointments that we're actually offering in general practice. That's not necessarily a measure of success, but it just shows that we are improving that. Some others that I wanted to pull out, we heard sort of hinted at the digital inclusion work that's going on in general practice. It's to be celebrated, and we continue to work on that. Something very close to a couple of GPs in this room's heart is the fact that going on 89% of our practices now are veteran accredited, and the work that's doing is really starting to see benefit with increased capacity in general practice through the ARRS roles, and we're really doing some great work on that interface between primary and secondary care at the moment, where cutting down on some of the bureaucracy and the tape and the handoffs that we have across our organisations will be reduced through that work. I mentioned previously at the board that we are 4 of our PCMs at the forefront of national work around 4 of 21 nationally. We're starting to see the results now and some of the outputs of that work, and I'll come back and present to the board later on. Thanks, Carolyn. If we can just go to the next one. So community pharmacy, unfortunate typo on the top one there, although there are many pharmacists who want to punch me. We've significantly increased the amount of pharmacy appointments, and that is genuinely diverting activity away from general practice around minor ailment conditions. And our community pharmacists are right at the forefront, really, of getting into some of our underserved communities around things like flu vaccination, COVID vaccination. So the sheer volume of work I just wanted to get across here around our community pharmacists. One of the risks that I'll come to later is the workforce in community pharmacy and the sustainability of that work. Next, please, Carol. Dental. I would say this, but I'm really pleased with the work that we've committed to as part of South Yorkshire. We have significantly increased the amount of urgent care dental appointments, additional dental care appointments in South Yorkshire in this year. Again, I'm not claiming by any means that this takes dental access off the table, but you'll see throughout the reports the good work that's being done in terms of a different approach to dentistry access. And we are at the forefront nationally in terms of some of the access, particularly of children. I think Sheffield has some of the best access to paediatric dentistry in the country. Again, that significant increase in appointments and access in this year puts a little bit at risk for next, and I'll go into that in a moment. Thanks, Caroline. So our plans for next year are very much around improving and building on the work that we've got at the moment. Want to really improve the work on the interface. We want to look at all of our locally commissioned services across South Yorkshire and ensure that is provided in the most productive and in a fashion that really improves access for our patients. Some of the work there on our priorities for dental. And what I haven't mentioned yet is optometry, but we do see great potential in the work of diverting demand away from our secondary care hospitals and into community optometry. We want to really accelerate that in this year. Caroline, go to the next one. There are risks, and they're well rehearsed. Gavin, thank you. This was written before the publication of the GP on Friday, and we're still working through some of the implications of that. I don't think this takes collective action off the table in its entirety. I think whilst it's admirable and positive that contract has been signed, in some ways the cat's out of the bag in terms of contract. And that dispute or that debate around recompense and will probably move more to a conversation as an ICB with general practice and LMCs across going
I
forward.
don't think it's impossible, Anthony. I think a statement this morning from the GPC has said that's where they're going to put their attention now, is at local systems. So that's been explicit.
So it's not off the table. And the other thing that I mentioned is that we're still in conversations with our local community pharmacy representatives about the potential collective action in that area as well. Dental, whilst I'm proud and happy of some of the improvement that we've done, it's in despite of the contract and dentistry rather than because of it. And until there is some fundamental reform of dentistry contracts, we are still in some ways into the wind on this. I mentioned the risk that we've got around workforce across all our contracted groups, and I would just like to put out the point that I said earlier when we were right back at Neville's story on a lot of the drug transformational work that we're doing at primary care is at the moment funded by non-recurrent monies. How do we make that mainstream and do some digital work with that? But I did want to finish on a positive if we can, Caroline, and you mentioned it earlier, Chair, you opened a workshop last week in Doncaster with over 150 professionals, heavily dominated by primary care, which I felt sent our message that we want to put primary care at the forefront of our sustainability and transformation going forward as a system. It's right at the forefront of our commissioning intention. Fought hard and sent the message, Chris, to put that right at the beginning of that document, which shows our commitment. We have got strength, I believe, strengthening relationships between primary and secondary care. I include mental health and community trusts in that conversation, and we need to build on that. And if we can put neighbourhood working right at the forefront of our plans, I do feel we can make a positive shift in the work that we're doing to ensure good quality and sustainability of general practice of primary care within South Yorkshire.
Anthony, thank you. Any questions for Anthony?
It's not really a question. Thank you, Anthony. I know a lot of work and collaboration has gone into this. And I just wanted to give kind of a positive perspective of the GP on the ground. The extra appointments have been invaluable. The respiratory group alone gave 1,650 appointments a week. And flu's been awful this year. Yeah. So having those appointments has made our job manageable through quite a difficult time. So that's really helpful. The visiting service, the visiting service takes a lot of pressure off us as GPs. I think it's a really, really challenging time, and they've just hit the nail on the head, and it really helps. I think we probably need a little bit more education for people engaging with our service so they see the people in the additional roles, because they still insist on seeing a GP a lot of the time. So maybe there's some work to do there. But I agree that, if we're looking at our transformation going forward, primary care will be invaluable.
Really helpful feedback. Thank you.
I just wanted to come back on the around digital, and I'm probably going to say this a lot over the next few months as the 10-year plan gets published and the conversations about digital go on. The stuff around digital inclusion skills is brilliant, and for some people being able to go somewhere, learn how to get on the NHS app and go through that process, absolutely brilliant. We mustn't lose sight of the fact, and I know I've said this before, we talk to communities all the time, and they are so far from that if we lose sight of the fact that the introduction of digital systems is excluding some people from being able to access GP appointments, we're going to be health inequalities are going to be driven in action. So particularly we did some work recently with asylum seekers and refugees. So many barriers, no smartphones, no access to data. It's not just skills that we're talking about. There are layers and layers of barriers. Did some other work with older people with respiratory conditions that don't own smartphones, that don't even sort of go anywhere near the sort of digital platforms that are offered to them. So we just need to keep, I think, centred in some of the things that we bring practical, considering, not just in the context of primary care, but that's what we're thinking about today. Those groups of people, whenever we think about it.
Thank you. But David and Kieran.
well, there might be one of the same thing. But, I mean, the team have a digital inclusion program. Maybe what the board may find helpful. So I don't know how we fit that in, but that's there to be considered. Because the reality is there are other avenues, like we talked about welfare. Some of it has no other alternatives, so we have to be able to reach into people to support them to use digital. Because, you know, to be honest, the government aren't great at doing this, so they're driving the only access to get benefits is to do an online questionnaire. So I absolutely agree with you, because I think if we look into our own lives, my father's got dementia. There's no way he's going to use a smartphone. That's just not possible. So, Kieran, were you going to say something?
Yeah, I was going to add on to the point about access to devices as well. So, as part of the digital inclusion program, it's not just about, you know, supporting communities to develop the skills and provide that support to them. Actually, we're working with partners to provide devices, to provide SIM cards, access to the internet, to implement Wi-Fi installations and so on. So we're trying to look at the whole thing, but recognising your point that even with all that, there will still be people who won't be able to get on that.
A point worth keep raising it, Lucy. I think that's entirely fair.
Yeah, I just want to support what Lucy said, really. I think it's great that we're doing as much as we can to help people to become more digitally included. There will always be people who won't be. And I think what we need to see as well is what options are available for them. So it's about digital, not by default, but by design for me. And I think as long as we've got some safety nets in place and we see what those safety nets are to ensure that people can't manage it any other way, still can talk to a person. Having spent 15 years working with older people, that's what they always said. And the other thing not to forget is people may have digital skills and may lose them. So if you get dementia, if your hands don't work properly anymore, whatever. So it's not just about, that's it, we've sorted it. In a few years, the problem will die out with the current generation of older people. It's not about that. It's about what else are we doing then to catch people if we can.
Yeah, thanks, Anthony. Thank you for that. Okay, financial delivery report, Lee.
I'll be very brief, I think, here. So just to report that the whole system we were seeing on 4.3 million. In month 9, we were 3.5 million. So it didn't get much worse, is the summary. And what we're trying to do now is trying to manage the 6.3 million deficit by the year end, which is going to be a challenge. But we're trying to manage that pretty constantly in terms of what extra things to do to further expenditure improvement between now and year end. I'll see month 11 earlier this week, and we'll regroup it and see what that looks like. So we're in close dialogue with NHS colleagues about accommodating that deficit position in a national position. I think that's all I need to say for now. There's a detailed financial.
We've got a private board meeting after this to talk about next year, but clearly this year has an impact on this. I mean, the only thing I'd say is I accept some of this might be balanced stuff, I accept that most of it thrown in. That's a 17 million spend we require between now and the year end. Is quite an achievement when we think if we balance, we've done well enough to kind of get together. Any questions on that? We've got all the discussion. Okay, finance and operational plan. Is that you, Lee? Do you start there?
So, thanks, Chair. The paper is very brief because we were still keeping the notes submitted. So, I think that's why in the statement. Obviously, we had to produce a first cut plan for the 27th of February. There were 3 elements to that plan: the operational targets, productivity pace, and the financial pace. None of the plans at this stage were triangulated, and because of the timelines, there was no correlation between the money and the operational targets. So you have to see what's written on this paper in that context. Obviously, there's significant work going on from the 27th of March to the 27th to the end of March to get to a final position. In terms of the operational targets, there's a summary in the paper of what was produced for the system. As it stands at the moment, all organisations are committed to deliver the elected recovery targets, i.e. the 18-week position, the backlog, 22 weekers. So that was a very positive, and there was a real statement by the chief execs last week that they were going to commit to that. We haven't, or Sheffield Teaching committed to delivering the 9% answer. They've submitted a plan that comes in 10% lower than that. That is predominantly around their workforce challenges, although I do think there's some challenge to go on between now and the end of March before we submit that. In terms of accident and emergency, again, Sheffield Teaching did come in with an accident 78%, and again, there's some checking challenge going in terms of that. Ambulance are currently working through where they're going to end. They've got a risk around their financial allocation to non-recurrent cash, whether that continues into next year or not, will depend on what we submit around ambulances. And mental health submission was there. There was huge data point issues in the original from the national team, so that's being worked through in terms of that. In terms of the productivity piece, and this is where Lee and I are on a different scale, because there's the operational, we need to do the nuts and bolts productivity, and then there's the longer term opportunity. Obviously, nationally, they're putting a big emphasis on productivity. My point back is that we've always needed productivity to just deliver the normal CIP in terms of that normal efficiency. To do more, which is what the ask is this year, I think to rely on productivity is naive from a national perspective. But each trust, including the mental health trust, have received a pack from NHS which identified the opportunity. And it's not a stretching opportunity, it's kind of putting them in the pack, what the opportunities are there. There's nothing obvious in the opportunity pack. There's lots of little pieces, but it does add up to significant chunks. So if you can deliver all, organisations were challenged with how much of this can be back in the first year, because it's not easy to get out, and there's some move back in the paper. From an ICB perspective, we've got productivity packs on the pharmacy and CHC, and we've also got some information in terms of non-elective admissions where we are, and again, I need more data because it's heavily caveated at this stage. It looks like we are the third worst ICB for our non-elective admissions. So basically saying we admit more. It says it's weighted. I need to see the data that it's weighted. And if you think from an ICB, depending on which data you look at, we're probably either the 4th or the 11th deprived or worst in terms of the population we serve. ICB. So we've got to do a bit of correlation. But in terms of opportunity, I think, and it's all in what we talked about today, our absolute drive has to be in terms of non-elective admission. And some of that is a hospital responsibility in terms of do they admit too many, and some of that's about our alternatives system. So that's a big piece of focus for us, I think, in the coming year. And I'll stop there. I think that's the operational bit.
I guess that wasn't new, Sarah. So during the I9 process that we took last year, it did highlight that I can't remember what HRG stands for. There's a certain group of conditions. There's our ambulatory care conditions, and then there's our stay where there was an area of opportunity identified to Lloyd. So I think we already kind of had a bit of a heads up that was something that.
I think we've been looking at our own internal place, how to correlate that against where we could be on in terms of the opportunity. So that's kind of a work in progress as we stand with them. Handle to late.
Can I just say, I talked to you about the change of chair at the NHS. There's one thing Penny dashes into, it's into the efficiency and productivity data. Big style. This isn't going to go away, just because I know.
So I agree with yesterday and said that they're looking, sorry to digress, but there's a productivity index now each organisation, and it is a much more complex calculation now in terms of how it layers up the different elements of it. I suggested to everybody on the from other organisations, there are national laws at the moment to listen to it. It's complex, but I'm a few pieces.
No way.
It's just to add to that. I mean, I think in some way we're probably ahead of the curve nationally because of the work we've done through the I9 process last year with Deloitte and the CASO for mental health organisation. think it's also worth noting the total scale of the ambition identified in the pact is probably less than half the financial challenge that we've got to address next year. So I think that focus on productivity was helpful and was a prize there. But I think we've got to get into the service change, transformation, which was the space. I think with productivity on its own is not going to get us there.
I agree, but if I'm at the centre, give Matthew, I'm going to say, before you tell me you're not going to hit all the targets or still on the targets, what your productivity be at the top, got it 10%. And there's a sit, and I want your efficiency to be clear. And that will be the challenge both for us and for all our providers, because this is now becoming a currency. Whether we agree with that or not, I said, in our way.
I think you're right, Chris, and I think the link between the size and scale, and so there was a report produced about the opportunities for back office section. It added up to 30 million, which I think is a prize. But when you looked at 100,000 in that finance department over here, 10,000 in the IT department over in another trust, it's going to be very difficult to do that.
I can't argue with that.
30 million is a big
30
number.
million is a number that. Which
I think it's an extension of the sort of conversation we're having about the value or not of benchmarking, because on back office, my trust is down 7.9 million. Having spent the last 3 weeks pouring over model healthcare, I can't find it. And I think that's part of the issue, is being really, really clear that historically the data's gone in on varying quality. Now it's coming out, and we've really, really got to focus on the quality of the data we're putting in, because the reality is assumptions being made on the back of it, and it is quite challenging. I think it is also true that model healthcare is more up to date now than I've ever seen it. In that, in reality, it's talking about the end of 24 now, whereas historically it's been considerably behind time. So I think there is something in it. So having a really good look at it in terms of whether there are any obvious things in there that we can collectively do individually or together, because I suspect that there are.
Yeah, I'm just going to be really quick, because I mean, we did mention something that made sure that the 7 hosted providers in the ICB had a position to understand opening financial challenge, and what did that start to look like? I just think we've got loads. So we'll have a conversation at the System Efficiency Board with the account officers and wider ICB colleagues tomorrow, just about the staging costs, things we need to do over the next 3 weeks. And there's loads of stuff we need to do. But just to echo what Kevin said, it's highly illustrative. We're going to have to absolutely stretch what we're doing in terms of responsibility, productivity, back, and we'll go further around technical efficiency. There's absolutely going to have to be a big strand of work which looks at what can we now stand behind in terms of the demand mitigation work into next year, which is why I had a bit of a moment on the place report around and we understand that really well. And then the third bit will be absolutely clear. Well, if that's as far as we can go with those two items, what else is it there? So we'll have that conversation at the System Efficiency Board tomorrow. We've got an option to go.
Thank you for that. Item 17, corporate assurance.
So briefly, 3 points, 3 things to tease out. Ask the board to note the contents of the report, where we set out governance activities within the period being considered, and the summary of business in the insurance committees that have met during that period. Second item is there is an exciting range of policies.
Dixie was my argument that you should attack it. But anyway,
it's all about there's an exciting range of policy procedures that have been approved by the executive committee, the executive group, and they're presented to the board for ratification. And the third item is the People, Workforce and Culture Committee have reviewed their terms of reference, and again they're presented.
Any questions on that? Thank you for that. Organisation development strategy. Christine's had to go along with Kathy because we're addressing the conference. Andy, I'm told you're introducing this
Yeah, so
Is
Christian,
that simply because we're sitting near her?
I think that she has given me 14 minutes notice to present this paper, but I mean, the Inspired Colleagues Plan, obviously, Inspired Colleagues is one of our three strategic aims alongside integrated care and involved communities. So really, really important. It kind of born out of the staff survey results, what came out of the running cost allowances programme and the Reconnect event. So everything that our staff were telling us, and kind of a plan was pulled together kind of to address that and support our staff and their wellbeing and how they go about doing their work. So lots of action has taken place. This report's been to the People, Workforce and Culture Committee, and it's been stuff by operational executive as well. There's lots in there, huge amount of work being done in communications and engagement, as you would expect, and kind of the proof of the pudding of whether it's been a success. We get an indication next Thursday, we anticipate, with the release of the NHS staff survey.
I'm not going to watch that, that's next week.
So that should be next Thursday. So as soon as those drop, we'll send a briefing out to the wider board so we can see that. But that will give us an indication of how well this Inspired Colleagues Plan has been embedded. And clearly in the paper, Christine talks about the actions we've taken in year one and what further actions we anticipate taking in years 2 and 3 as well.
I mean, that will presumably go to the People Committee, but I think it'd be helpful if that just go out to the board. In theory, it could be public as well. We'd send it out Thursday, it'd be brilliant.
Yeah, we'll aim to send it out the minute it drops on the national website.
Yes, of course.
I was just going to say, I mean, as it happens, we've got an all staff webinar on the same day, so we'll be talking to all our people as well about it. I think just to say, this is a really important piece of work, and I think one of the things that's really important to recognise is it does reflect the conversation that we've had with our people within the organisation. And I think it's also worth noting that we've had a difficult birth as an organisation, gone through a process of organisational change. But I think it's a credit to colleagues who work within the ICB, the way they've engaged with us as an organisation over the past year. Obviously, we had the big event in Doncaster last summer, and there were a number of really important steps that were agreed as part of that, like really focusing on improving appraisal and PDR and how we support people to even their best selves at work, also around communication and how we make sure that everybody works is kept informed. Recognition, we mentioned the start of all earlier in the day, but just encouraging colleagues to appreciate each other, but also for the organisation to recognise the work of colleagues. So I think there's been some really good foundations laid. I think the Inspired Colleagues Plan is a critical part of it. And I think this is an important paper. I just think we probably should receive it in that spirit.
I think that's right. I mean, I agree with you, Andy. Next term is critical. It says we put a lot of work in. Christine's led a lot of work. It's really important work. I've seen a number of manifestations of that personally. Yeah. I think what I'm really looking forward to, I hope, is that feels different when we get the staff survey results on Thursday.
Yeah, and just building that, I think we've got a really high turnout for the
which in itself is good.
Exactly. It really will be representative of what.
You want to add, Jahida?
I was just going to say, from the NED perspective, I'm sure we can really reassure people you see the amount of work that's it's been absolutely brilliant. And we also want to commend the team as well, because on kind of well-being, like they haven't just taken an ICB focus, they've taken a wider workforce to focus on that, and that's been brilliant to see that from a system perspective on workforce, they've extended that to BTP colleagues and other parts of the system. That's been really, really positive. I think going back to your question, turnout was looking like 650 plus, so really good figures in terms of what's about there. I think we're going to be looking with interest what that staff survey says.
That's a really big percentage of staff. Way
yeah, yeah, exactly. And I think as well, firstly, what we're hearing that things are shifting towards more positive feedback from staff. But I think it'd be interesting to see what that actually turns out to.
Andy, thank you for picking that up. Sure. And we've then got some items for information, July minutes. Anyone want to pick up any issues around these? Okay, so that finishes the meeting. Now, we said we have our private board meeting at 1. I'll keep it at 1 o'clock to give people time to start lunch and coffee and breaks, given that you never take any notice of me when I try to pull you in a bit more. So give you a chance to hear the rules. So you'll be back here at 1 o'clock to private board meeting on next year's plan. Okay, everybody, you've got 39 minutes. Thank you.
Guys,